Privilege to welcome you all to the first Upper GI Live web air organized by APELS, Asia Pacific Endo-Laparoscopic Surgery Group. We received 250 registration to our Zoom webinar today, mainly from surgeons and fellows in the Asia Pacific region. As a medical academic group, APELS has been organizing various types of physical training workshop in Asia Pacific region in the past 5 years. That inspired many surgeons. As we now emerging into a new era, I'm proud to see the host of this event, Professor Philip Chiu and Dr. G.D. Rao, have been making tremendous effort to organize a high standard and interactive webinar focusing on the topic of upper GI cancer therapeutic treatment. The event capitalize our strength and realize our commitment to you, to cultivate an intensive learning culture and enhance professional competency in endolaparoscopic surgery to meet the ever-changing challenges in today's clinical situation. The 3 hours of webinar today will be put into two key parts. In the first half of the event, we capture the essence of the APELS legendary workshop with the presentation of some notable speakers of the region. Professor Hiroya Takeuchi from Japan, Professor Joong Park from South Korea, Professor Suthep Udomsawaengsup, Thailand, Dr. Duy Long from Vietnam, and Dr. Hon-Chi Yip from Hong Kong to share their approaches and to some key procedure and provide updates in the field. Second half of the webinar, we have invited 4 young surgeons who attended the APELS physical workshop in the past 5 years to join us in sharing cases on their learning and challenges since they completed APELS workshop. I'm very glad to see the familiar faces back and help build this community together. As the chairman of APELS, I look forward to the rapid growth of the society and wholeheartedly commitment to educate, train, and innovate in every aspect of endoscopic and laparoscopic surgery. Once again, I welcome you all and sincerely hope that you enjoy the program. I look forward to seeing you all in the coming training workshop, both online and in person. Thank you.
Thank you very much, Mr. Michael Lee, for these enlightening words and opening remarks. And we are very delighted and fortunate to have APELS, which is always dedicated to the training and education in endoscopic laparoscopic surgery for Asia. So without further ado, let's start our first session. So I'm Philip Chiu from the Chinese University of Hong Kong, and together I'm chairing this session, the first session with Dr. G.D. Rao from AIG, Hyderabad, India.
Hi,
so G.D., hello.
Hi, good morning,
yeah.
Philip.
So perhaps, yeah, good. Yeah, now it's afternoon for us. You are probably even in the late afternoon. So G.D., may I invite you to introduce the first speaker for the session?
Thank you so much. At the outset, let me thank the entire executive and all the board members of the APELS for doing human service to teach people, to train people in the Asia Pacific regions. Sincere thanks to the President, Michael Lee, who is untiring efforts, have been responsible for these continued CME programs that have been happening. Initially, we used to have them live, but now because of the COVID, we have gone virtual. Thanks, Michael, for all those untiring efforts that you have put in through the years to bring this education closer to people who cannot afford to reach these big consultants who are all taking part this morning. So we have very lively sessions this morning. Actually, without much ado, I think we'll start the first session on esophageal cancers. We have 3 talks in this. May I invite Professor Hiroya Takeuchi from Japan. He'll be talking on minimally invasive esophagectomy for treatment of squamous cell carcinoma. Professor Takeuchi?
Yes, hello.
The screen space and the aid space is all yours.
Okay. Uh, Hello, everyone. Thank you very much for kind introduction, Professor Chiu and Rao. I'm Hiroya Takeuchi from Tokyo, Japan. I have two topics today. And first one in the minimally invasive esophagectomy for treatment for squamous esophageal cancer. I have no COI for my presentation. As you know, minimally invasive esophagectomy, MIE appeared attractively about 30 years ago, and MIE is beneficial in terms of better cosmesis, less invasiveness, and it also had educational benefits. Actually, MIE has several surgical procedures such as complete thoracoscopic and laparoscopic esophagectomy, and the robotic esophagectomy, and the mediastinoscopic transhiatal esophagectomy. In Japan, esophageal squamous cell carcinoma is very common, more than 90%. And these patients with esophageal squamous cell carcinoma are mainly treated with thoracoscopic esophagectomy at this moment. And the number of the patients with robotic esophagectomy is still small, but it's increasing year by year. Most important part in MIE for esophageal squamous cell carcinoma is precise and meticulous lymphadenectomy along the right and the left recurrent laryngeal nerves. Actually, we try to perform very careful and precise lymphadenectomy. You can see a right subclavian artery here and the right recurrent laryngeal nerve. And you can see the optic curve and the recurrent laryngeal nerve here. So these lymph nodes, incidence of these lymph node metastases are very, very high, especially in patients with esophageal squamous cell carcinoma. That's why we try to perform the precise lymphadenectomy along the recurrent laryngeal nerve and try to prevent nerve injury and palsy after esophagectomy, even thoracoscopic esophagectomy. So let's see the comparison data between open esophagectomy and the MIE. This is our national data, which compare the open esophagectomy with MIE. In Japan, MIE showed significantly longer operation time, but less blood loss, and less respiratory complication and the superficial SSI. However, we have to be careful about the more incidence of recurrent laryngeal palsy and the 30-day reoperation rate. What about other countries' data from UK, Netherlands, EU? Interestingly, there are similar trends. I mean, in terms of respiratory complication, MI is better than open esophagectomy. However, we have to be careful about the more incidence of surgical complication in MIE, especially in experienced institutions. What about long-term outcomes? Recent meta-analysis showed that long-term survival after MIE seems acceptable, but the non-inferiority or superiority to open surgery has not been scientifically evaluated, especially for esophageal squamous cell carcinoma. So in Japan, we have been conducting a JCOG 149 randomized control trial, which compared the open esophagectomy with thoracoscopic esophagectomy. The primary endpoint of the study is overall survival, and this is the first randomized control trial to verify the long-term survival after MIE for esophageal squamous cell carcinoma. It's an ongoing study. What about robotic assisted esophagectomy? As you know, Da Vinci system is very common, especially in the prostate or gynecologic surgery, and also spreading to the gastrointestinal surgery, including esophageal surgery. Recent meta-analysis showed the robotic surgery is beneficial in terms of the less incidence of recurrent nerve palsy after esophagectomy when we compared with thoracoscopic esophagectomy. We also studied the robotic esophagectomy using the Da Vinci exercise system from 2018. The patient position in the prone position, and we placed the 4 trocars, 4 robotic arms, and 1 assist arm, 1 assist trocar. So total 5 trocar in for robotic esophagectomy. The patient position like here, and the robotic trocar for 4 arms, and the assistant port here. And I'm here as a primary surgeon here in the surgeon console. So I'll show you the short video for robotic esophagectomy, especially for left upper mediastinal lymphadenectomy along the left recurrent region, most difficult part in the MRE. So you can see a cranial side and a caudal side. Here is esophagus, and this is trachea here, slightly rotated. And you can see that very thin left recurrent region of here, and these surrounding yellow tissue, including the lymph nodes around the left recurrent region. So robotic esophagectomy is useful for precise and meticulous mediastinal lymphadenectomy. And actually, in our data, robotic esophagectomy is beneficial for less incidence of recurrent regional palsy. So, as you know, robotic surgery can use, the very smooth forceps motion and no tremor and the fixed operative field and the 3D high vision view. These are very beneficial points of the robotic esophagectomy. You can see the lymphatic chain around here, and we carefully detach from the left recurrent region of here. So this lymphatic chain is carefully separated from the left recurrent region. So this tiny branch is cut after the clipping, like that. And we have to be careful about the thermal injury of the nerve, or excessive traction or compression of the nerve should be prevented. We have to be careful about the nerve injury and the palsy. So careful and very soft handling is very important. Sometimes we use sharp dissection using like scissors. I show you. And these lymphatic tissue are carefully separated from the nerve finally. So this lymphatic tissue is completely separated from the left recurrent region up here. And after that, we moved on to the bifurcation. You can see the trachea and the right main bronchus and the left main bronchus. So this vessel sealing system, vessel sealer is useful. This bending procedure is useful. And already we immobilize the esophagus from the anterior side and the posterior side in the mid to lower mediastinum. So we separate, mobilize from the left mediastinal floor here. So this is a final view after that. So far, there is only one small randomized control trial which compared robotic esophagectomy and open esophagectomy. Actually, the mobility is significantly better in a robotic esophagectomy. However, very small sample size and long-term survival, no evidence, but looks very similar at this moment. How about the esophageal squamous cell carcinoma? My close friend from China, Professor Li and Professor Chiu from Taiwan, they have been conducting the randomized control trial, which compared the robotic esophagectomy and the thoracoscopic esophagectomy for esophageal squamous cell carcinoma to evaluate the incidence of left recurrent laryngeal palsy and the number of dissected lymph nodes. So this is my last slide for my first presentation. I believe the essential for curative treatment in esophagectomy, we need intensive aerosol resection by MRE, and also less post-operative complication is very important. And we also need intensive preoperative chemo or chemoradiotherapy. And these factors are all supported by the team management, such as the nutritional support and the intensive rehabilitation. Thank you for kind attention.
Thank you so much, Professor Takeuchi, for that beautiful presentation. You have a couple of questions to post, actually, Professor Takeuchi.
Yes.
Yeah, I think, can the delegate say this actually, which is the most important area for precise lymphadenectomy in MIE for esophageal squamous cell carcinoma? Lymph nodes along the recurrent laryngeal nerves or lymph nodes in the lower mediastinum? Karen, are we taking the poll, Karen? Okay. The second question, Karen?
Oh, I have just one question.
Okay, fine. That's okay. Thank you so much. Professor Takeuchi, I just wanted to ask you one question.
Yes.
The incidence of recurrent laryngeal nerve and the mediastinal lymph node yield seems to be better in robotic. Is it basically because of the energy source that you're using or because of the vision that you get on robotic?
Okay. That's very important commented question. Actually, incidence of lymph node incidence of recurrent laryngeal palsy is improving year by year in Japan, even in thoracoscopic esophagectomy or under robotic esophagectomy, because we at this moment we utilize the intraoperative nerve monitoring. Looks like a thyroid surgery. Yeah, so we notice the several points to prevent nerve injury. One is we try to avoid thermal injury. So any energy device such as vessel sealing system or a harmonic scalpel like that, we never use, especially along the nerve. And the other important point is we should not extend, we should not add the traction, excessive traction to the nerve and the compression. These are the big damage to the nerve. So robotic surgery at this point, robotic surgery is better to handle around the nerve carefully and softly. That's the reason why the robotic surgery is better in terms of the less incidence of the nerve injury.
Thank you so much. Actually, there's a question about ICG from one of the attendees, but I think Professor Takeuchi will cover the role of ICG in minimally invasive esophagectomy in the next talk.
Yes.
Professor Takeuchi, can you do the next presentation on the role of ICG in MIS esophagectomy?
Okay, thank you very much. So I will continue the next topic.
Yeah.
Oh, okay, sorry. This is our national data about the esophagectomy, especially short-term outcomes. anastomotic leakage 13.3% in Japan. But as you know, anastomotic leakage after esophagectomy results in the very serious complication and mortality. So why anastomotic leakage occurs, especially after esophagectomy? As you know, there are several factors. One is systemic reason, such as malnutrition, chronic disease, and comorbidity, drug, radiation, steroid, smoking, like that. And we have to be careful about the insufficient blood supply in anastomotic sites and overtraction at anastomotic sites, immature anastomotic procedure, technique, and infection. We currently focus on the insufficient blood supply in anastomotic sites. And this is my procedure in our institution to make a gastric conduit. We routinely make a gastric mobilization laparoscopically, but we try to make the gastric conduit using a linear stapler extracorporally because of we try to make a good, long and straight, extended gastric conduit. So we also try to preserve the omentum as much as possible to maintain the microvascular network. And also we try to preserve the right gastric epicuric artery and the right gastric artery network and the arcade. And width of gastric conduit is usually 4 to 5 centimeters. And we prefer to do hands-on anastomosis to perform the esophageal gastric anastomosis in the cervical wound. Usually we use in MRE. So as you know, recently we focus on the blood flow of the gastric conduit evaluated by the ICG fluorescence imaging. Several years ago, my close friend Dr. Koyanagi reported that the blood flow speed of the gastric conduit assessed by indocyanine green fluorescence imaging is very important to predict anastomotic leakage after esophagectomy. So we also routinely perform the ICG fluorescence imaging of gastric conduit. We usually inject the indocyanine green 5 mg, 5 milligram intravenously, and we utilize the PDE product by the Hamamatsu Photonics, that's a big company in my place, in my work town. And I'll show you several cases of the ICG fluorescence imaging. So this is gastric conduit. This side is the top of the gastric conduit, and this is the root of right gastroepicuric artery. This is case number 1. You can see, extracorporeal observation. You can see the arcade of right gastroepicuric artery soon, like that. And you can see the rich blood flow in the stomach, and the intramural extension occurs subsequently. Then maybe in this patient, this is a demarcation line for optimal, anastomotic size. So this optimal line or distal side should be, used for anastomosis. This is another case, case 2, similar ICG fluorescence imaging. You can see the very rich and the long arcade of RGA blood flow up to here, and after that you can see the intramural extension of blood flow, and in this case maybe this line, the demarcation line, as an optimal line of the anastomosis. So this is case 3, another case. You can see the very beautiful, arcade of RGA, and interestingly flow in and flow out to the left gastric artery. And in this case, the demarcation line is very clear. You can see here. And I try to, set up this line as an anastomotic site. So this is another case. You can see no communication between right gastric artery arcade and left side gastric epicuric artery. But in this case, intramural blood flow connect the right and the left side like that. And you can see the, this demarcation line here. So we noticed that there are several components of the blood flow of the gastric conduit. One is extramural arterial flow, mainly from the right gastric artery here. And the second one, the intramural artery flow from here to here, about 40%. And about 70% of patients has communication between right and the left gastric arteries. And finally, about 20% of patients has external and retrograde flow out and flow in. Very interesting, unique arterial flow. And this is the most important slide in my presentation. Anastomotic site and instance of leakage in our institution. This is arterial flow zone from right gastric epicuric artery, and after that, intramural extension of blood flow diffuse zone. And this is the demarcation line here. And these area, arterial area, instance of anastomotic leakage and only 6.2%. However, on difference and diffuse zone, poor blood flow area, the instance of anastomotic leakage reaches 23%, and that's a big difference. So ICG fluorescence imaging is very useful to decide the optimal line for esophagogastric anastomosis after esophagectomy. So this is very, shocking case, but a very interesting case. A case with intraoperative injury of RGA arcade. Actually, in my institution several years ago, my young colleague injured the arcade of RGA, right gastric artery here in laparoscopic gastric mobilization. So how should we do? Anyway, we performed the ICG fluorescence imaging before making the gastric conduit using a linear stapler. Fortunately, in this case, you can see here, blood flow from the right gastric artery is very rich. This is the injured point here. And the intramural gastric flow is also very good. So we try to make a full stomach gastric conduit. So in this case, we reject only lymph nodes along the lesser curvature side, number 3A and number 1 and number 7. So after making a gastric conduit, you can see the very rich flow of the right gastric artery and intramural gastric flow. So in this case, we can avoid the necrosis of the gastric conduit, and we didn't need to use jejunal reconstruction and colonic reconstruction. So this is my last slide. Intraoperative evaluation of blood flow by ICG fluorescence imaging in the gastric conduit is useful to predict the risk of anastomotic leakage after esophagectomy. Thank you for kind attention.
Thank you so much, Professor Takeuchi. Actually, there's a question from Professor Takeuchi to all the participants. Now, is ICG fluorescence imaging useful to prevent anastomotic leakage after esophagectomy? As we take this poll, actually, there are a couple of questions, actually, Professor Takeuchi. Now,
yes.
we know that ICG is a good way to objectively assess. Now, is there any way to quantify the blood flow? I mean, you understand, initially it used to be only visual perception, but now we have an ICG to more objectively tell us that it is better perfused. But is there any way to can quantify this, the arterial flow? Dr. Walid wants to know, how can we measure the intramural arterial flow?
Okay, thank you for a very good question. Actually, I show you several patterns and the components of the blood flow, mainly from the right gastric artery, and the other one is intramural flow. But that depends on the patient, each patient. So very wide variation of the blood flow. Actually, to make a good gastric conduit, we have two ideas at this moment in Japan. One is very wide gastric conduit, to maintain the intramural blood flow. But usually in such a case, we can make only relatively short lengths of the gastric conduit. And the other idea is very narrow, very thin, maybe 3 to 4 centimeter, very relatively narrow gastric conduit. And in such a case, we try to preserve the omentum as much as possible to maintain the blood flow from the outside of the stomach in the omentum microvascular network. So at this moment, it's completely controversial. We discuss every day, which is better, thick one or narrow one. But according to the ICG forensic imaging, you can decide for each patient, I believe.
One last question, Professor Takeuchi.
Yes.
This is from Shivrajan, who wants to know which endotracheal tube do you use when you're using MIS esophagectomy?
I'm sorry?
What type of endotracheal tube do you use when you're doing MIS esophagectomy?
You mean?
The endotracheal tube? The anesthetic tube? Yeah.
Okay. And tracheal and...
Yes, tracheal tube. Anesthetic tube.
The nasal tube?
The anesthetic endotracheal tube.
So a single lumen with blocker or double lumen for the endotracheal.
I see. I'm sorry. For anesthesia, right?
Yeah.
Yes.
Okay. Sorry for, yes. Usually in tracheal, but it depends on the anesthesiologist. But we try to, we ask anesthesiologists to use, soft tube. Because, yeah, as much as possible to mobilize trachea and rotate the trachea to perform the, precise lymphadenectomy along the rectorecurrent.
Thank you so much, Professor Takeuchi. Yeah. I think I'll hand it over to Philip Chiu to introduce the next speaker on endoscopic diagnosis and early esophageal cancer.
Thank you, Jiwi. So next presenter is Dr. Hon-Chi Yip, who is working at the same unit as me at the Device Surgery, Chinese University of Hong Kong, Prince Hospital, and he's now associate consultant of the team, and is going to tell us about the endoscopic diagnosis and treatment of early esophageal cancer. Hon-Chi, please.
Thank you, Philip. It's my great pleasure today to share with you on another aspect of esophageal cancer management. I'm sure most of us here are surgeons, but I think it's still quite important for us surgeons to understand more about endoscopy, because I think this is one of the rising trends in managing esophageal cancers in terms of endoscopic management. So just a recap, we are still having quite a significant disease in our part of Asia, where esophageal cancer is still having a very high incidence. majority of them in the male, and we're seeing most of them in the squamous cell carcinoma. So that's also what I'm going to focus on today. Of course, everyone knows that diagnosis of esophageal cancer at an early stage is probably most important for a better survival outcomes. So you can see back in 1999, studies from Japanese surgeons after surgery, you can see a very good survival trend for those patients who suffered from T1 cancers. And in addition, in current era, there is also a potential that we can avoid esophagectomy with early disease with only local treatment. So the issues are, how do we improve our detection rate of early esophageal cancer? And secondly, what's the role of endoscopy in the armamentum of treatment in esophageal cancer? So first talk about detection and characterization. So I would start with a poll. Very quick question. So which of the endoscopic view would you routinely use when you're examining the esophagus? Okay, so let's see. So we are having a 50-50 between white light endoscopy and narrowband imaging. So I'll just go on and move on, and we'll probably know the answer later. So this is what we can see for an early cancer with using conventional white light endoscopy. So we need to be very careful in looking at very subtle color changes or surface changes. Or sometimes you can see all the vasculature along the esophagus. When there is disruption of these vasculature, they're also a sign that there could be potential pathologies located in these regions. But I must say it's quite difficult to see. Another method commonly used is the use of, glucose iodine. So chromoendoscopy has been there for decades, and generally the current recommendation is to use a lower concentration of glucose iodine, at most about around 1%, which would give you the ideal situation, ideal view without causing a lot of irritation to the esophagus. And what we're looking for is areas that are unstained by iodine due to glycogen depletion. And it has a very high sensitivity but variable specificity in terms of detecting cancer or dysplastic lesion in the esophagus. If you see pink color sign, which is seen here in the lower end of the right side of the photos, which you could observe after a few minutes after spraying glucose iodine. And this is a highly specific sign for a high-grade lesion or an early cancer. The specificity is more than 90%. Of course, nowadays we have a digital image enhancement, such as the narrowband imaging from the Olympus. When you use narrowband imaging, the essence is that it will see the pathological area quite clearly with a demarcated area that is brownish in color. So we call it a demarcation line. And inside this demarcation line, we can see abnormal vessels. So we call these vessels intrapapillary capillary loops, or IPCLs. So the more disrupted these vessels are, the higher is the grade of the destruction, and the higher is the depth of invasion of these cancers. So the reason for the brownish color change has been reported by a group of Japanese endoscopists, where they found that in cancer versus normal epithelium, there is a significant thinning of the epithelium and also thinning of the keratinaceous layer of the mucosa. And this probably contributes to the change in the light reflection when you shine the blue and green light of NBI onto the esophageal mucosa, and causes a background change in the background color, brownish color change. As for the IPCL, there were 4 cardinal changes as reported by Professor Inoue. back in 2002, where you would see dilatation, tortuosity, variable caliber changes, and non-uniformity of these IPCL morphology, as you can see on the photo. So the IPCL essentially are the topmost small capillaries inside the mucosal region, where they have progressive changes in a neoplastic transformation. So the utilization of NBI has been compared with white light endoscopy before in a large randomized trial from Japan, where they randomized patients with a high risk of esophageal squamous cell carcinomas into NBI followed by white light, or white light followed by NBI. So this is what they found, is that when you compare the overall performance of NBI versus narrowband imaging, the sensitivity or the detection rate is actually much higher if you use NBI first, and rather than if you use a white light endoscopy. So the conclusion of this study is that not only for esophageal cancer, but also for head and neck cancer, the NBI has a much higher sensitivity and overall accuracy in diagnosis of high-grade lesions or early cancers in the esophagus. So another meta-analysis showing that the NBI performed the best, and also after Lugos endoscopy and white light endoscopy in terms of assessment and detection of second primary lesions at high-risk patients. So with increasing change in the depth of invasion, there are increasing change in the IPCL morphology. So the question is, can we predict depth of invasion with image-enhanced endoscopic technique? So another poll. So perhaps this quite an obvious answer is that it's yes. So because of time, we'll probably skip the question. And so actually there is a recent classification from the Japanese Esophageal Society where they look at the morphology of these IPCLs. If they are loop-like vessels, they are called B1, corresponding to M1 to 2 vessels. B2 are non-loop vessels corresponding to M3 invasion or SM1 invasion. Thick green vessels are corresponding to SM2. So these are examples. I couldn't use too much time, so you can see these photos that will highlight the changes in the IPCL that correspond to the depth of invasion. The same with the avascular area, which is also reported in the same classification systems, originally reported by Professor Arima. So the overall accuracy of the JES classification, the positive predictive value, negative predictive value are quite good, except for B2 vessels, which has a slightly lower positive predictive value. And that's also the reason why some experts actually suggest the use of additional EUS if you see B2 vessels and you're not sure whether it's a deep invasive lesion or a superficial lesions. So by and large, NBI with magnification has almost the same performance with EUS. So except for selected situation, it might not be necessary for all cases to do a probe-based EUS just for the sake of assessing the depth of invasion. So I'll talk about, of course, endoscopic resection. So as a general rule, we have to resect those lesions that could be completely removed by endoscopy and in the absence of lymph node metastasis. Of course, there are special scenarios, for example, the use of adjuvant chemo-RT for esophageal cancers, and some for gastric cancer is with the addition of sentinel biopsies or sentinel basin dissections. So we have to be able to predict the depth of invasion by endoscopy, as I mentioned just now, and also to predict the chance of lymph node metastasis based on the suspected depth of invasion. In esophageal cancer, traditionally, it's considered that the lymph node metastasis rate is 0 if the lesion is invading only to the M1 or M2 layer. And if it's M3 or SM1, the lymph node metastasis rate variables. So it could be up to 10%. Of course, for SM2, SM3, the rate of lymph node mets are very high. So this is the recent Japanese guidelines is that for M1 or M2 lesions, they are amenable for endoscopic resection. If you have an M3 or SM1 lesion, but histologically there is no lymphovascular permeation, then it's also one option for endoscopic resection as a relative criteria. So for instance, for this lesion, what would you offer the patient? What kind of treatment would you offer the patient? So ESD, EMR, primary chemoradiation, or primary esophagectomy. So let's see the answer. Okay, so most of the participants chose endoscopic submucosal dissection. So I think perhaps everyone knows what ESD is, but before we embark on ESD, we can think about EMR first. So it's not a bad thing to do EMR on patients. So there are many ways to do the EMR, conventional EMR, strip biopsy type of procedure, cap-assisted EMR, or band-assisted EMR. I don't have time to go deep. Of course, EMR is much shorter procedure. It's much easier to perform. There is a reduced chance of perforation. The downside of EMR is that you might end up with a piecemeal resection or incomplete resection or difficult pathological assessment and higher local recurrence rate. So how do we choose in the esophagus? So there were studies that were done before showing that if you are doing EMR for lesions that are less than 1.5 centimeters, essentially CAP EMR performed almost the same as ESD in terms of on-block resection. Sizes larger than 1.5 centimeters, of course, has much higher rates of incomplete resection. And if you have incomplete resection or failed on-block resection from the same study, you can see that the chance of local recurrence would be higher. So generally, what we recommend is that for lesions larger than 1.5 centimeter is better done with ESD. For those less than 1.5 centimeters, perhaps a CAP EMR would be an adequate option. So ESD is reported back in 2001 from the National Cancer Center of Japan. Long history of this procedure has been reported. I don't want to go into deep detail, but basically it allows an on-block resection of a mucosal tumors so that we are not limited by the size of the snare as in EMR. So just an example of the procedure. This is a lesion, early lesion in the esophagus. Actually not very big, it's only about 1/4 circumference. We do marking with this specially designed knife. It's the ESD knife, we call it dual knife. And after marking, we inject solution onto the submucosal layer so that we can lift up the lesion away from the muscularis propria layer to ensure a safe plane for dissection. And then we do a mucosal incision circumferentially around the lesion, and then resect the lesion on block after we do the submucosal dissection. So due to time limit, I think I would not be able to show the entire video. So you can see the submucosal layer being lifted up here. Okay.
Is it possible that we can fast forward the presentation? Yeah.
Okay, sure. So clip traction technique is very useful, and then as reported recently, so ESD as compared to surgery has been found to have similar survival, and but of course lower complication rates. And recently there's a study from Japan showing that even for non-curative resection after ESD, if they are still submucosally invasive, adding adjuvant chemoradiation actually would give an excellent survival for these patients as well. So it's considered as one of the option after endoscopic resection. So in conclusion, so I think early diagnosis is of course important, and the use of image-enhanced endoscopy improves the detection and characterization. And I think the use of ESD has revolutionized the field of endoscopy and allows resection of endoscopic resection of esophageal cancers. So that's the end. So thank you very much.
Thank you, Hon-Chi. I think because of the time that we have to move on, so I think that we'll just skip the question. And if you have any question, you can actually type on that. And I think Hon-Chi can take his time to respond back with the typing on the Q&A
Yes.
column. So I think we will have to move on. And the next session will be chaired by Professor Long and also Hon-Chi. So please.
Okay, thank you very much, Professor Philip Chiu. Can you hear me, please?
Yes, yes.
Okay, thank you very much. Yeah.
Yeah.
And next session for the gastric cancer. The first speaker, I want to introduce my friend, Professor Joong Park from Korea. Professor Joong Park is a professor division of gastrointestinal surgery, Department of Surgery and Cancer Research Institute in Korea at Seoul National University. And he also the Secretary General of Korean Cancer Association. He director of the accreditation committee, director of planning committee, director of insurance committee of Korean gastric cancer and metabolism surgery in Korea. He also a chairman of Korean reduced pork gastrointestinal surgery study group, and he is a member of many associations in the world. Now, please start your speaker. Okay.
Thank you very much. Hello, everyone. Thank you very much for kind introduction, Professor Long. I will share my presentation. I'm very pleased to present laparoscopic radical D2 thoracostomy and various techniques in esophageal jejunostomy. I have no COI about my presentation. According to Japanese gastric cancer treatment guideline, recently published in 2020, D2 dissection include D1 plus 8A, 9, 11P, and 11D, and 12A. Very interestingly, number 10, that is lymph nodes around the splenic hilum, is not included in D2. So this number 10 dissection is optional. It's based on the surgeon's preference now. And regarding surgical options, after distal gastrectomy, various types of gastrojejunostomy there are, but after toral gastrectomy, now the standard treatment, standard anastomosis is Roux-en-Y esophagojejunostomy. However, after laparoscopic toral gastrectomy, we can use circular stapler and linear stapler, and we can perform various anastomosis methods. So let me introduce each details. First one is my short video clip of D2 lymph node dissection for the high body advanced gastric cancer. First, starting dissection around the left gastroepiploid vessels and ligate left gastroepiploid vessel here. And because this patient had a high body, huge gastric cancer, so I performed hilar dissection around the spleen. So this is a distal splenic artery, and carefully dissect around the splenic hilum. We can see distal splenic artery and splenic arteries around located in the hilum of the spleen. And then moving on to the around the esophagus, approach it into the lower mediastinum, continue to the dissection, soft tissues around the lymph node, lower mediastinal lymph node. And I usually suture right cruce and left cruce to widen the lower mediastinum opening, and continue to dissect all soft tissues around the esophagus. And this is a thoracic aorta. After clearing all low mediastinal lymph nodes, this is the final view of low mediastinal lymph node dissection. I cut the esophagus for specimen removal. And I used the OVIR for esophagojejunostomy method. So because the anastomosis level is very high, it is located at the mediastinum. So I used the OVIR, and finally I performed the esophago end to side esophagojejunostomy with circular stapler here, and divide the jejunal stamp. Next one is one example of a circular stapler low anastomosis. This patient had high body cancer. So I used our own laparoscope pulse string clamp here. It's just like open method, and insert MBL intracorporeally, and then insert the circular stapler. And this is a final view of esophagojejunostomy with circular stapler using laparoscope pulse string clamp. Next one is reconstruction using linear stapler. If the anastomosis level is a little low, functional end-to-end method is good. However, if the anastomosis level is high, for example, in the mediastinum, we should perform overlap method like this. So this is a short video clip of functional end-to-end esophagojejunostomy. So insert cartilage, jejunal side, and carefully insert MVR in esophagus, distal esophagus, and perform the firing, linear stapler, and we close another linear stapler. So this is the functional end-to-end esophagojejunostomy. And lastly, this is overlap method esophagojejunostomy. This is a robotic esophagojejunostomy method. So because the level is a little high, so I chose the overlap esophagojejunostomy method, and I closed the common opening with a suture to prevent stenosis. According to our comparative study, side to side and versus end to side, more leak from side to side. But so I prefer the circular stapler method, but this is my initial experience. So now the complication rate is comparable between two groups. In summary, After laparoscopic gastrectomy, there are circular stapler method for lower anastomosis using laparoscopic pulse string clamp, Lapjack from Korea and the PSI from Japan, commercially available. And for high anastomosis, we can use OVIL. And regarding linear stapler method, if the tumor, if the anastomosis level is low, we can use functional end-to-end anastomosis. If the anastomosis level is high, we perform overlap method. And laparoscopic pulse string clamp method for lower anastomosis and overlap method for high anastomosis are my favorite esophagojejunostomy method. Thank you very much for your kind attention.
So thank you very much, Professor Park. So I think Professor Park has prepared some questions. So this is the first question. So what are your indication of lap total gastrectomy in gastric cancer? Okay, so shall we end the poll? Okay, so it seems that 1/3 of them choose each one. So yes, so what do you think?
Multiple choice, yeah.
Yeah, I think all three are probably good options. So second question. Okay. So same, many people use different techniques. Okay. So is that all of the poll? Oh, third question. Okay. I think probably without the need to do station 10 nowadays, the total gastrectomy are easier than the past, probably.
Yes, right.
Yes. Anyway, maybe I can ask a question to Professor Park. So I think after all, what you show are very, very nice techniques. So, but I think as a beginner, I think each of us may need to master one first so that they can ensure a safe procedure for their patients. So which one do you think is the easier to learn if you're really starting to learn a laparoscopic esophageal jejunostomy?
Yes, the most important thing is the education. So the beginner should see the many videos and many procedures in practice. After then, joining or participating in some WNRAP, the animal workshop for the hand sewing. After then, might be the learning curve will be overcome. You can perform esophagojejunostomy.
Okay. So I think because of time, we should move on to the next lecture. So it's my great pleasure to introduce the moderator of the same session, Dr. Long. So I think he needs a little introduction. A very famous surgeon coming from Vietnam. He's a deputy head in the Department of GI Surgery, University Medical Center from Ho Chi Minh City in Vietnam. So he's also a board member of the APELS and also members of the ELSA, SAGES, and other numerous societies. So today he's going to talk to us about carcinoma of stomach, standards of lap D2 radical subtotal gastrectomy. So Dr. Long, please.
Okay, thank you very much, Dr. Hon-Chi. Thank you very much. Firstly, I want to thank Professor Michael and Professor Philip Chiu inviting me to share with you the lecture, Standard of Laparoscopic Radical D2 Subtotal Gastrectomy. As you know, for the treatment guideline 2014 and 2018. We have a D2 gastrectomy for the tumor with advanced gastric cancer or the positive lymph nodes in CT scan. So until now, we have a widely accepted indication for D2 lymphadenectomy for gastric cancer is the first potential curable for the clinical T2 to T4 tumor or the clinical T1 but positive lymph nodes on CT scan. As you know, because preoperative and intraoperative diagnosis regarding the death of the tumor, invasive and nodal involvement remain unreliable, so that we have to perform D2 lymphadenectomy whenever the possibility of nodal involvement. For the treatment guideline of the 2019, for the standard D2 lymphadenectomy for subtotal gastrectomy, we have to remove the group 1, 3, 5, 6 for D4SB and all the lymph node localized suprapancreatic area such as 12A, 8, 9, 7, and 11P. And I remind you that anatomical border of lymph nodes in the similar the picture here. And for the standard D2 dissection for this gastrectomy, we have to start for following the 8 steps. The first step we perform omentectomy, and the second step we dissect the group for SB, and next step is for D, and the next step for group 6. Remember that for group 6 we have to dissect separately group 6V, 6A, and 6I, and after that we decide on the superior aspect of the duodenum to ligate the right gastric artery for dissect the group 5. And next step we transect the duodenum. And the very important step, we have to perform supra-area dissection to remove group 8A, 9, 11P, 12A, 7. And the last step, we have to dissect along the lesser curvature to remove group 1 and 3. And for the principle of lymph node dissection, we have to remember that we have to decide or unblock, shouldn't pick up any lymph nodes, and we have to ligate the vessel from origin, and we have to make sure the optimal layer principle. Because when for the dissection, we have to remove all the lymph node suprapancreatic area, so they have many risks, serious risks such as bleeding or bile, sometimes pancreatic leakage after surgery, so that the thin loose connective tissue here between the autonomic nerve surrounding the major artery and adipose consist of the lymph node there. Had to dissect its connected outermost layer. I show you a short video how to before outermost layer. The common hepatic artery, the lymph node and connective tissue, touchy tissue here. They are very thin connective tissue here, have to dissect in this place to preserve the autonomic nerves surrounding the major arteries. The patient position and trocar position for subtotal gastrectomy. We use 5 trocar. I show you the short video clip for the laparoscopic subtotal gastrectomy. The first, we hand the left liver lobe, and we decide to remove all the omentectomy, and decide to ligate the left gastroepithelial artery from origin to remove group 4SB, and decide along the greater curvature to remove group 4D, and come back to the pancreatic head to separate the first right gastroepithelial vein, gastroepithelial artery here, and the infrapyloric artery to remove 3 group of 6, and dissect duodenum to ligate the group 5, right gastric artery to group 5, transect duodenum, and transect the suprapancreatic area. We make sure the outermost layer principle here, and we preserve some nerves surrounding the common hepatic artery, splenic artery. They set along the splenic artery to remove group 12P, 11P, and to ligate the left gastric vein, and continue to dissect in group 11P, and and group 9 in right side and left side of the celiac trunk. And we have to ligate the left gastric artery to remove group 11. And we remove all the lymph nodes along the suprapancreatic area. And the last step, we have to dissect along the laser curvature to remove group 1 and 3. And we transect duodenum, transect the stomach. After before this lymphadenectomy, you see, all lymph nodes have to remove and preserve the artery. Okay. For ICG, using ICG for mapping lymph node, I think it's a guide for us to for lymphadenectomy. You see, after we have to remove all the lymph node tissue, connective tissue died by ICG. We have to inject 1 day before surgery. For ICG, it's a guide for us to remove all the tissue died the ICG. Group 6, ligate the for guiding which ICG, I think that it's better to mapping the lymph node and the fatty tissue on group 6, especially in infrapancreatic area. Using ICG is guide for you from mapping lymph node. It's clearly, and to remove all the lymph node is better. Group 9, group 11P, remove all the lymph node, connective tissue, fatty tissue, died with ICG. Okay. Ligate the left gastric artery and group 8A. Okay. For perceptomy, that means we have to, for the tumor penetrating in the serosal of the posterior gastric wall, we have to perform perceptomy. That means we have to remove all the peritoneal lining of the bursa ommentalis from the anterior plane of transverse colon and the pancreas, with aim of removing the microscopic tumor deposit within the omental cavity. Some of the research in the world, especially in the Korea, have the controversy. Hon-Chi and the study randomized control trial from Osaka University give the best 5-year overall survival in vasectomy compared to without vasectomy. And Dr. Yang in China, he performed randomized trial and give a similar, especially for total gastrectomy. Vasectomy is better than non-vasectomy. But the negative study, especially the you see, especially in the Japan, we have a large scale of the randomized control trial. Have the survival benefits of procedure have denied for all patients registered. Especially the night have a before meta-analysis have no significant between overall survival. So that we think vasectomy might be performed by experienced surgeon 44-1 at the tumor located at the posterior gastric wall. The techniques, you see, for technique is not very difficult. We use the spatula to perform the blunt dissection to remove the anterior lip of the transverse colon and pancreatic seat. You see. You see, after before vasectomy, all the pancreatic have to remove. For the dissection, the group 12B and B, for the Japanese guideline 2019, this groups is not including 42 dissection. But as you know, biliary obstruction after gastrectomy due to hepatic lymph node metastasis. But interoperability, it's very difficult to mark the border of group 12A, 12B, and P. Some other in the world, she give the metastatic of group PP about 10% in similar our studies. So we suggest that 12B and P dissection may be performed by T4A at the lower third of stomach or septic 12BB lymph node undetected interoperability. The esophageal for dissect of the group PP With I said in failure and posterior hepatic hilum to remove all lymph nodes surrounding the common venous portal vein and proper hepatic artery. After perform total and number 12 dissection, you see. And we have a conclusion. D2 lymph node indicates for the CT2 to T4 tumor or have a suspected lymph node on CT scan. And principle for the two dissection is with two dissection and block and automatic like a principle. We have a step, 8 step for dissection. And perceptomy may be performed by experienced surgeon for selection patient. I mean that the tumor T4A at the posterior gastric wall. And total number 12 dissection may be performed by the selection patient, especially with suspect lymph nodes to PP intraoperative. Okay, thank you very much for your attention.
Thank you, Dr. Long. So do you have questions for the poll? Okay, yes.
Yes, the question, I want you to know us what the best surgery have to select for each patient. The patient 60 years old, we have the tumor about 2 cm at the lower third of stomach, but on CT scan, we have one lymph node, 1.5 cm and the common hepatic artery. What kind of operation should be? I think that D2 is the first choice. Next, please. For D2 subtotal gastrectomy, what the lymph node routes is not included. Yes, for the updates guideline, the group IP is not included for D2, standard D2. Next question. Perceptomy for gastric cancer might be performed for now perceptomy now not abandoned, but it should be performed. It may be performed by the experienced surgeon for the tumor T4A located at the posterior gastric wall of the stomach. Thank you very much.
Thank you, Dr. Long. So maybe there's just one short question being asked in the poll. So it's for ICG, do you inject it real time or do you inject it 1 day or 2 before the operation?
Yes, for ICG, I have injected 1 day before surgery. We inject about 4 positions surrounding the lesion 1 day before. Yes.
Yeah, I think it depends on the indication. Perhaps Professor Takeuchi will know best about the indication for sentinel lymph node biopsy. He's one of the experts. So if you're doing a standard D2 and use ICG to guide the D2, perhaps 1 day before is the best, as Dr. Long has mentioned. But if you're doing for sentinel lymph node, then perhaps you need to inject it intraoperatively.
Okay,
so,
thank you very much.
Yeah, thank you, Dr. Long. So would you like to introduce the third speaker for us?
Yes, and next speaker, let me see. Next speaker, I want to introduce my Professor Suthep. Suthep, are you ready?
I am. Hi.
Yes.
Good afternoon.
Yes, Dr. Suthep, he is a board member of Asia Pacific Endo-Lap Surgery Group's APELS. He many run of the association, director of advanced laparoscopic and bariatric surgery in Chuo University in Bangkok. He is president of the endoscopic and ELSA and president of LES. He also a Congress president of the first Asia Pacific Congress in Chiang Mai, and he was governor and treasurer of the LSAN APHE. He also a secretary general in the Mekong Endoscopic Surgery Develop Association is MESDA. Please,
thank you, Long. Thank you, Hon-Chi. Thanks, Macaulay and Philip GV. Good to see you, Dojung. This is APEL family, so we gather again. So thanks for the talk. Let me go to my topics. For the last one for gastric cancer, let me share my slide. This is what APEL has been preparing for you for the upper GI cancer, therapeutic cancer. So you can see therapeutic treatment. And my talk is the palliative treatment for gastric cancer. So should we do endoscopic stenting, laparoscopic bypass, or the palliative gastrectomy? Professor Long has been showing to you already from the latest version of the Japanese gastric cancer treatment guideline, the 5th edition. So you'll see that endoscopy is also included as the T1A or limited tumor to the mucosa without any node. And also you have a good presentation and also a beautiful video of the technique of gastrojejunostomy and the standard technique of D2 gastrectomy by both Professor Park and Professor Long. Then what's about metastasis one? So if you have a look on the former version, it's been recommended for palliative treatment. But anyway, I think the group of the patient who are in the middle means that with node number 16 or even the resectable liver metastasis or peritoneal lava cytology positive or local peritoneal metastasis, all of this been very active issue that we try to get better than palliative treatment for the patient, but anyway, it's still under the study. Then if those other metastases, this group of the patient would be categorized for the treatment as palliative care. So then if talking about palliative surgery, what should we do? So I think it's been seriously studied, and those who have complication, for example, obstruction or bleeding, this group of patients would need the palliative resection or endoscopic treatment as the palliative care. I tried to review, started from 2013, you will see that comparing between gastrectomy versus no resection. So you see that it favor on the palliative gastrectomy comparing to no resection in terms of survival. And then if you have a look on subgroup analysis, those resection with chemotherapy have shown better result. So in that time, I would think that the palliative resection has been the primary care for this group. But anyway, I think Professor Park has been very contributing on this part together with Professor Yang and a colleague from Japan, Professor Fujitani. So they randomized the patient who are non-curative factor. So this study is a Regatta study, a randomized control trial. It started with 175 patients and enroll into the chemotherapy alone versus gastrectomy plus the chemotherapy. At the end of the study, I have 74 and 76 into the study. What I have found is very landmark on this group of the patient. You will see that the overall survival has been no different between these two groups. And have a look on the progressive free of the survival. So also showing same result. So I think this study from Lancet 2016 has been emphasized that chemotherapy alone remain the standard for the non-curable gastric cancer. But anyway, if this is a study from Japan, you will see that for those who are in advanced gastric cancer and unfit for chemotherapy, like recommended by Ricketts study, this study also have been shown that the group of gastrectomy would take longer time and have more bleeding. But at the end, you will see that the gastrectomy have the survival time longer, significantly comparing to bypass. Next, it's about the stenting. You will see that this is also the endoscopic treatment, especially for the patient of this group. I think if they do have obstruction, their treatment would be comparing between endoscopic stenting and the bypass. So you will see that it also favor on the endoscopic stenting in terms of the starting of the intake, and without any more comorbidity and mortality you will see on this study either. So then most of the more important thing is that the gastric emptying time has been delayed, then the endoscopy group have shown better result. So this is the comparing study to compare the gastric outlet obstruction between the stenting and the gastrojejunostomy. You will see the meta-analysis also showing that the reintervention and the obstruction would be more on the stenting part. But anyway, if you have a look on this study, it's showing the partially covered stent comparing to uncovered stent. It found that the successful rate would be more on partially covered stent, and the obstruction rate would be less on the partially covered stent. But anyway, the stent migration will be associated with this group too. So this is the meta-analysis to see the stenting, and then you will see that the covered stent would be better in terms of the prevention of the further obstruction, but same thing, the migration will be one of the things that it been in the account for the rationale to use. So ladies and gentlemen, my APELS fans, the palliative treatment for gastric cancer is necessary. But anyway, if the patient doesn't have any symptom, the chemotherapy is recommended. The palliative treatment would be indicated with a patient with complication. The endoscopic stenting showing that it become relieve early symptom. Last, the laparoscopic bypass will be preserved and it showing less effective for symptomatic relief, especially for the delay of the gastric emptying. Thank you very much.
Okay, thank you very much, Dr. Suthep. What's your question?
No, I don't have. Please proceed.
You have a phone question?
No, I don't. So you can proceed.
Okay. Do you have any question for this session?
Professor Suthep, perhaps I should ask a question. So in your practice, in patients who are having obstruction, so your preference is to do GJ or would you do a endoscopic stenting? Which one do you choose?
For the obstruction, yes. As recommended and shown by the study, I do prefer the endoscopic stenting with the partially covered stent. So that's my favorite for this group of patients.
Oh, I see. I think one of the most important thing that you've mentioned is that the term of palliation has been changed a lot in the past few years, because many of the patients who were considered as non-curative are now having many more treatment options. So do you have any suggestion on how we should tackle on this area of potentially treatable or curative but metastatic patients?
Thank you, Hon-Chi. This is very important part of the study. I mean, the active research has been doing very much to try to help the patient who we usually put them on unresectable or palliative treatment. So you see that those who have, for example, liver metastasis or the cytological LAVAS positive, on this group of patients, there has been several studies to show that they do have so many pre-op chemotherapy, and then try to have, for example, high-pack treatment to get the patient for the treatment. So I think soon in the future, the treatment guideline and the palliative group of the patient will be less and less, and those who can be treated with more advanced pre-op and multimodality treatment would be helping for this group of patients.
Yes, certainly. I think it's a very exciting field for us as in upper GI surgeons. So in the interest of time, I think we should close the gastric section. And I think Professor Suthep will be the moderator for the upcoming session. So Professor Suthep, we'll hand the podium to you.
Thank you, Hon-Chi. Thank you, Long, for moderating the gastric cancer session. Now we've been moving to the GIST, which is also very active and very interesting topics. So first, it's our course director that I would like my period to invite to introduce him. He's a director and chief of the surgical gastroenterology, GI oncologist transplantation service, MIS, as the AIG Hospital or Asian Institute of Gastroenterology, Hyderabad. He also the immediate past president of the International Hepato-Pancreatobiliary Association of India. He's the president of the Society of Gastrointestinal Endoscope of India. Please, our course director, Duy Long, for the topic of Endo-Lap treatment for GIST. Professor Long.
Thank you so much. I'll straight go on to the topic, and thank you for the introduction, Suthep. Gastric GIST are increasingly being detected. Surgical resection is recommended for all lesions which are more than 2 centimeters in many guidelines because of the malignant potential that is seen in these patients. We seem to understand these tumors very well, including their biological behavior. And due to the rare possibility of lymphatic metastasis, local R0 resection with less extensive excision is always the target of surgical treatment. And segmental minimally invasive resection techniques based on sound oncological principles seem to have gained inroads into practice. And these seem to have better functional outcomes, and patients seem to recover faster following these minimally invasive techniques. Now, gastric interventions in 2020 could be the surgery, which it could be open surgery or laparoscopic. On an endoscopy side, it is basically procedure-based, based on the site, size, and the mural extension of these tumors. Now, endoscopy versus laparoscopy, conventionally we use the endoscopy. The pros of endoscopy are flexible, maneuverable. We have the advantage of using narrowband imaging. The cons are orientation is difficult, accessories are limited, and anesthesia sources are limited. On the laparoscopic side, we have rigid instruments, dissection, anastomosis, and hemostasis is possible. ICG and infrared laparoscopy have made big inroads into practice. The biggest disadvantage seems to be because we may not be able to do real organ preserving procedures in some of these patients. So it is something like this. When initially we started doing laparoscopic procedures, we used to do these sleeve resections. You can see that this is what we mobilize the greater curve and do a sleeve resection of these tumors. This has been the standard of practice. The biggest disadvantage of this is, you can see this cartoon which shows that you do this laparoscopic stapling. This is the conventional wedge resection that you talk about, and you can see this. This is the margin that we get. There is the margin towards the stapler line is closer, and the margin away from the stapler line seems to be slightly bigger. And the conventional wedge resection is too close to the tumor and involves excessive wall dissection on the laparoscopic side. Now, taking this, now the laparoscopic surgeons have changed their technique, wherein they started making an incision on the gastric wall and excising it, doing a wide excision and subsequently closing this defect using laparoscopic suturing technique that have gained, that the expertise has been gained over the period of years. Now, this is another example to show you that the gastric wall has been incised and you do a wide local resection and then you do intracorporeal suture to close the gastric defect and also the anterior gastric wall. So these techniques have become very, very popular, and minimally invasive laparoscopic techniques have made big inroads into the clinical practice. Likewise, endoscopy has become, on the other side, we started doing endoscopic submucosal resections. Now, basically depending on the site size, but the limitation seems to be whenever the lesion is extending transmurally. And basically the biggest limitation seems to be that the entire resection seems to be done in a distended stomach, limiting the wide dissection margins that we talk on surgical side. So in a distended stomach, the whole thing gets stretched and we may not get that wide resection that we talk about on the laparoscopic side. So if you see this, we have endoscopy and laparoscopy, which have their pros and cons. And then if you combine these two things, actually, that is what results in this endo-laparoscopic cooperative surgery, wherein you're combining both the pros and cons of endoscopy and laparoscopy together to enhance the results of some of these gastroesophageal stromal tumors. And conventionally, endoscopy used to be limited to luminal side, and now there's going outside the lumen, and laparoscopy, which used to be outside the lumen, as I've shown you, they started getting into the lumen, and there seems to be an interface wherein endoscopy and laparoscopic cooperative surgery is very, very essential to do some of these tumors which are in the gray zone for treatment as in today. So laparoscopic and endoscopic cooperative surgery is a combining procedure which involves both endoscopy and laparoscopy. And there are various terms that are used in this endoscopic, laparoscopic cooperative surgery, but the commonest, and these are basically based on the site of the tumor and the extent of neural extension that we see of these stromal tumors from the mucosa, submucosa, the circular layer of the muscularis propria, and the longitudinal layer of muscularis propria. Depending on these, various types of procedures have been described to make sure that we have a complete R0 resection of these tumors. But what is more important in laparoscopic and endoscopic cooperative surgery is these four procedures. We talk about classical laparoscopic and endoscopic cooperative surgery, or in news, it is non-exposed endoscopic wall inversion surgery, or a clean net, which is a combination of laparoscopic and endoscopic approaches, or especially for neoplasia with non-exposure techniques, and we have a modified net. The theater position is something like this, wherein we have a combined endoscopy and laparoscopy towers, which are used in the same operating room, and we have the endoscopists doing from endoscopy side. We have the surgeon standing in between the legs and the assistant standing on both the sides, and the scrub nurse and the power units are distributed like this. And this is how the combined or a hybrid theater looks like, wherein you have a combined endoscopy and laparoscopy unit. And we have multiple monitors to make sure that both the endoscopists and the laparoscopic surgeons are comfortable viewing. And we can have a PIP of these things so that people doing these procedures can watch these procedures simultaneously. Now, as a cooperative surgery, breeding tumors like this sometimes would require some endoscopic assistance to make sure that you have a good resection of these tumors. This is basically an endoscopy that is used only to assist a laparoscopic dissection, but here endoscopist does not have any big role other than just assisting the laparoscopic surgeon to make sure that you have a complete resection of this tumor. Now, this is an endoscope-assisted laparoscopic intragastric resection. A PEG tube was inserted initially, and then we have the standard laparoscopic harmonic scalpel, which is passed, and to resect a GIST that is very close to the GE junction. These tumors traditionally used to go for some sort of proximal gastrectomy with an intrathoracic anastomosis, or maybe even a total gastrectomy in some of these patients. So these procedures, minimally invasive procedures wherein you combine endoscopy and laparoscopy, seem to minimize the resection and seem to preserve the organs. Now, a beautiful classification that comes for this endoscopy and laparoscopic cooperative surgery, of wherein all these four techniques are involved. Basically, it all depends on whether you're doing a resection and anastomosis on the luminal side or a resection and anastomosis on the laparoscopy side. A beautiful dissection to show that this is the classical laparoscopic endoscopic cooperative surgery. This is what you call as the non-exposed endoscopic wall inversion technique, and a combination of laparoscopic and endoscopic approaches for, especially for neoplasia, and a modified clean net wherein we close it from the other side. So just to show you a couple of examples of this, this is a laparoscopic assisted endoscopic full thickness. So you're taking the help of the endoscopy to make sure to identify and make sure that you make the incision based on the endoscopic assistance on this side. So, and then you can do a full thickness resection. And once the full thickness resection of this tumor is done, we can close the defect laparoscopically and then subsequently make sure there is no leakage of this site of resection. And also maybe with the use of ICG, we can check for the vascularity of the gastric stomach subsequently that is done. So this is basically an endoscopic assisted. Likewise, this is another one which is close to the GE junction. Actually, this patient would have required a total gastrectomy or a proximal gastrectomy. Here, just to show you that whenever we're doing this procedure, both the endoscopist and the laparoscopic surgeon should be adapt to using this instrumentation. The endoscopist should get used to using this flexible instrument in the peritoneal cavity. So it is a sequence. It is not that you can learn all these techniques overnight. Here you can see this, we have done this and subsequently brought this endoscope onto the peritoneal cavity. We did a full thickness resection. Now here we are assisting, making sure that we are identifying the lesion because it's not visible on the serosal side, make an incision based on the endoscopic assistance, and then subsequently do this resection which is along the lesser curve. And the biggest advantage is just to share with you that doing this procedure, the stomach gets deflated, but just to get this endoscopic cooperative surgery to the next generation, we have to ask the endoscopist to learn how to maneuver this flexible scope. Here we're just trying, though this can be extracted laparoscopically, we're just trying to see how we can put this specimen into a laparoscopic bag and extract it. So this is basically a combination of endoscopic and laparoscopic surgeons who have to adapt to various techniques and know how to maneuver this instrumentation in the peritoneal cavity or on the laparoscopic side. And suppose if you have to extract it endoscopically, you can get it, attach it to the Riles tube and then pull it back through the esophagus or maybe put in an over tube and extract this laparoscopically. Now this is a neat technique wherein we make a laparoscopic seromuscular inject, initially inject submucosally and then make a seromuscular incision on the laparoscopic side. And once you have done the seromuscular, make a through and through seromuscular incision, suture so that this entire lesion which has been dissected goes on to the luminal side. And once this is done, as you're doing this, you can further make this lesion prominent on the endoscopy side by putting in some sort of a Surgicel in between so that the lesion becomes more prominent on the endoscopy side. And once this is done, the lesion can be extracted using ESD techniques on the endoscopy side. So this is especially used for neoplasia, wherein we don't have any spillage of the contents into the peritoneal cavity. So basically, laparoscopic and endoscopic cooperative surgery, the resection line minimizes the surgical margin, securing an adequate distance from the tumor. And there is a huge number of publications which have come in to show this laparoscopic endoscopic cooperative surgery is very useful, especially for gastric. Just you can see this huge number of series which is coming in to show. And it also shows the role of the endoscopy and the role of the surgical team and the type of closure and how we retrieve the specimen either endoscopically or laparoscopically. So basically, this defines the role of surgeons, defines the role of the endoscopist to make sure that each person is adapt to what he's doing. This is basically summary of what we do. Now, very laparoscopic, simple wedge resection. When predominantly it's a laparoscopic procedure, basically it is assisted by an endoscopist. So the classical areas, we have endoscopists and laparoscopic surgeons at equal role. And you can see that's how each person takes role in this and they clean that. So basically now the procedure time, the role of these two people seem to be very defined. But at the same time, both the endoscopist and the laparoscopic surgeon should be adapt to this different viewing and a modified viewing that we see, and we should be able to operate when you're seeing especially the PIP. What happens is very, very difficult when you're seeing the images simultaneously and trying to operate is something like an ERCP tries to do the endoscopy and the fluoroscopic image. But here, the laparoscopic image and the endoscopic image are totally different. So we have to make sure that both of them are in the same line to make sure that we get good dissection. We have huge data to show that these can be performed very easy, very efficiently with absolutely no recurrent rates and very, very minimal morbidity. And various procedures have been described, and there are a lot of pros and cons of all these procedures. Now, what we talk about is the laparoscopic endoscopic cooperative surgery. The gastrotomy can be close to single port incision, combines advantages of both endoscopy and laparoscopy, no restriction on the size of the tumor. But it requires both, as I told you, requires an advanced endoscopy and laparoscopy skills, and it is restricted to more high volume centers. There is some risk of spillage and contamination, but it is again cannot be used for gastric cancer, but it has to be used, can be used for GIST. But the clean net and the modified clean net that I would describe can be the ones which can be used for oncological or gastric cancers. So now with the introduction of robotic, we seems to be having an endo-robotic cooperative surgery, which seems to be coming in. There is some beautiful data to show that robotic surgery in place of laparoscopy seems to have certain advantage in some locations. It is just an entrant into this laparoscopic endoscopic cooperative surgery. So we'll be showing robotic endoscopic cooperative surgery in future. We just have to wait for the data to come and see how it is going to be useful. So laparoscopic endoscopic cooperative surgery is a novel procedure that minimizes the invasive damage to the patient and preserve the physiological function of the residual function while securing the oncological benefit. Currently, many physicians can fully utilize the advantages of LECS for submucosal tumors located especially at the GE junction by avoiding a conventional total gastrectomy or a proximal gastrectomy. This requires close cooperation between skilled surgeons and experienced endoscopists. It could be surgeon, endoscopist. There are many tips and pitfalls that should be discussed between the surgeon and endoscopist to accelerate this collaboration during LECS. It can be safely introduced in a facility in a phase-wise manner, either by surgeons or endoscopists with advanced skills. Is a function-preserving surgery with oncological safety and main indicated for gastric submucosal tumors, especially close to the GE junction. And LES, it has various possibilities and further developments. And as we learn more and more of these techniques and more of these technologies get incorporated into this, and the surgeons and the endoscopists get used to this, I'm sure we'll be able to do better procedures, more physiological resections, more good R0 resection at the same time maintaining the organ preservation in GIST. Thank you so much once again for the patient hearing. And a couple of questions here. Which is the best option for gastric GIST close to the GE junction? Fantastic. It seems to be good. The second question is, now, this is a slightly more political question. It may vary from region to region. It could be surgeons and surgeons also. Surgeons are surgeons. But basically, surgeon becomes mandatory. But the other side, whether doing the endoscopy is being done by an endoscopist or a surgeon endoscopist, is a totally different thing. But with more and more expertise that is being gained by the endoscopist, I think a surgeon endoscopist combination is ideal to perform this laparoscopic endoscopic cooperative surgery. Absolutely right. I think with more and more this thing, absolutely right. Actually, it all depends on various, and with more and more of this being done, I think between the cooperation between surgeon and physician, I think more and more of these procedures could be done by combined technique.
Thank you, TV. Thank you very much. I think the topic of the GIST, the treatment by endoscopic and laparoscopic collaboration, it's one of the most important that APEL aim to be bringing together those two techniques, endoscopic and laparoscopic. So thank you very much. Very beautiful presentation. Because of time, we move to the next topics will be given by our course director for APEL webinar. Very much good friend, Professor Chiu. He is a professor in Department of Surgery, Prince of Wales Hospital. the Chinese University of Hong Kong. He also served as the Assistant Dean for the External Affairs for Faculty of Medicine, the Chinese University of Hong Kong. He's very expert and very famous on the endoscopic treatment for several types of diseases. So please, Professor Chiu, for the topic of the endoscopic treatment started from submucosal to full layer of the resection for GIST. Professor Chiu, thank you.
Thank you, Suthep, and thank you very much. So I wish to share my slide. So can you see my presentation? Okay, so it's my pleasure to speak about endoscopic treatment for GIST. And because GE has done a great job, so it's difficult for me to win over only for endoscopic treatment alone. But I try my best to show you how good would be. So with the treatment of endoscopic treatment alone. So there has been an increasing potential of for therapeutic endoscopy from first phase to second phase and then first phase. And the recent adoption of the submucosal tunneling procedure has been developed by Professor Haruhiro Inoue, first for the Cohen procedure in 2008. And now I think, oh, okay. So, sorry, I have to share my slide again. So now I'm not using the, okay, please wait.
That's perfect. That's good.
Can you see my presentation mode?
Yes,
okay.
But could you go to the
Make it full
slideshow?
screen.
Yes.
Okay, okay, please wait, please wait. Also, please wait. Okay, is it better now?
Yeah.
Perfect.
Perfect.
Okay, okay, good. There has been a development of the first phase endoscopy. So it's been defined as if the lumen is historically first and the peritoneal cavity is the second, and then the known to the endoscopist, then the submucosal space is the first phase endoscopy. So the kind of submucosal tumors now that we are encountering in the stomach is most likely GIST tumor, Lao-Malma, and for the GIST tumor, as illustrated by Professor G.V. Rao, indication for surgery is now more than 2 centimeters. While the surgical principle, it's only required a margin negative resection. So with the integrity of the tumor capsule. So lymph node dissection is not necessary. So that's why I think with the combination of development of the first phase endoscopy with the submucosal tunneling, we can reach this submucosal tumor, and then we can perform the dissection. And the technique of the POET, the per-oral endoscopic tumor resection, or the STIR, submucosal tunnel endoscopic resection, requires us to have a development of submucosal tunnel 2 centimeters proximal to the tumor and dissection around the tumor. Finally, with the creation of the distal pocket and then completion of the resection of a tumor from the muscle. So here I'd like to show you a video clip about the performance of the POET procedure. So firstly, we developed a submucosal tunnel and proximal to the submucosal tumor. So this tumor located in the esophagus. So this is most likely a Lao-Malma. So what we are doing is we are developing the tunnel all the way and exposing the submucosal tumor. So with the use of the flexible endoscopy and also the dual knife, we'll be able to develop a submucosal tunnel and dissect around this submucosal tumor. So you can see that these tumors are usually arising from the muscularis propria layer with a adhesion around. So a lot of time we have to develop the submucosal tunnel and develop two tunnel around the tumor and also a distal pocket before we dissect at the base so that we have more space for the manipulation. So you can see this is the submucosal tumor, the whitish one, and we are dissecting at the muscularis propria layer and separate this tumor from the muscularis layer. So this is the final part, and I usually make a combination of the dual knife and also the IT knife for the dissection. So sometimes we encounter very thick vessels, so we need a coagulation grasper to coagulate before we cut onto the vasculature. So this is a final part of the tumor retrieval. So a lot of time it may be difficult because of the large size of the tumor. So finally, we close the mucosal entrance with the crypts. And this is a study we report in surgical endoscopy about the series of POET procedure on 51 patients. The location of this tumor are most likely selected to be at the cardia, at the lesser curvature, at the antrum, or the esophagus. So I think as GV demonstrated, if it's located over the greater curvature, a lot of the time a laparoscopic resection will not be that difficult. But if a tumor is located at the lesser curvature cardia, it could be jeopardizing the GE junction and ending up in the narrowing. So a lot of time we may need a good resection. So endoscopic resection may be having the advantage. So the mean operative time is 90 minutes and the mean hospital stay is 3 days. Some of the procedure require conversion to laparoscopic tumor retrieval, and some were converted to endoscopic full thickness resection, especially for those located at the greater curve or the antrum. But I think there are also challenges in performing the endoscopic resection for GIST. Some of the challenges will be that is technically demanding, and also there would be a risk of involving the tumor resection margin because it's dissecting close to the capsule of the GIST. So we worry about the local recurrence. So that's why the development of laparoscopic endoscopic coronary surgery, or we can actually move on to endoscopic full thickness resection. So endoscopic full thickness resection is not a very new technique because if you remember in the 1990s, actually the colorectal surgeons are doing EFTR for early rectal cancer using this TEO device. And I think this has been evolved and there are new devices coming up, for example, like the full thickness resection device, FTRD, but this device is limited by the size of the specimen resected. So it's currently indicated, I think, for mucosal neoplasia with dense submucosal fibrosis that make a ESD difficult, or a submucosal tumor like a GIST tumor. So relatively contraindicated in a large size tumor, not retrievable per oral or per anally, or some location with anatomical limitation like in the esophagus or the duodenum. So the instrument that I prepare for the use of the EFTR would include the ESD devices, retraction like a dental floss or the string clip device, or maintenance, and also the maintenance of environment with the CO2 insufflation, and also with a closure device, for example, like Apollo overstitch. So this is a video to demonstrate the endoscopic full thickness resection procedure. So this is a GIST located at the gastric cardia. And the first procedure step will be to open up the mucosa distal to the tumor. And then afterwards, we will expose the gastric GIST tumor. So you can see that I have injected normal saline indigo carmine with epinephrine at the submucosa. And then we are now dissecting over the submucosal space, and we are exposing the tumor. So I would only perform half circumferential mucosal incision because sometimes we can save some of the mucosa for a better. So you can see we are now dissecting at the tumor margin, So in order to avoid getting entrance into the tumor margin and breaching the capsule, I would prefer to dissect at the muscular layer. So it's again a combination of use of the IT knife and also the dual knife. And right now I'm exposing the tumor, and actually we are already full fingers inside the peritoneal cavity. So after and the string technique to achieve a good retraction. So my idea is that if we are retracting the tumor to the inside of the stomach, this is totally the territory of the flexible endoscopy. So if we are putting the flexible endoscopy to the outside of the peritoneal cavity, it may be difficult to manipulate. So, so you can see that further retraction device is inserted so that we can and after pulling the tumor inside, you will be able to see the serosal site and also the margin of the tumor. And then I would further the dissection by the use of the IT knife so that I can completely resect with a good resection margin. So this tumor is now pulled inside the stomach totally, and I can complete the resection with the IT knife. So this is the final part with some muscle layer and also the good margin of the tumor. And then after resection, the first thing to do is to grasp the tumor by the rod net and take it out because I don't want to drop the tumor to the peritoneal cavity. So final part is a closure of the defect, and I generally will use the polo over stitch to close the defect so that it can have a good suturing. So to avoid a leakage. So so a lot of time I use figure of 8 endoscopic suturing. So this is the Apollo over stitch device. It can pass the needle in between the needle holder, and you can achieve a full fingers suturing mechanism. So you can see after passage of the suture through one side, I then pass to the other side. And then the final part is dropping the needle and then tighten up the suture by the casing. So this is the final part, and you can see a complete full fingers closure of the defect. And there are other methods to close. For example, this is a loop, detachable loop snare from Olympus, and you can actually grasp the loop with a clip, so multiple clips and the loop, and then finally close the loop to tighten all the clips. So this is also very handy. While for surgeon, I think the better method that we believe is the use of the suturing. So I like to use the Apollo over stitch, and now it's developed into a single channel system as well. So a comparison between EFTR versus stir technique, and there's no difference between the two groups in terms of the age, gender, and the location of the gist. A lot of more of the TRIPS method were used for the submucosal tunnel endoscopic resection as compared to full fingers, where I use a lot of the suturing. While when we are looking at the hospital stay, it seems that the EFTR has a 1 day longer hospital stay because after EFTR, we tend to slowly resume the diet. And while the complication rate, there's no difference in terms of a leakage. There's no patients sustained from leakage. The need of release of pneumoperitoneum is higher for the EFTR because we already puncture into the full fingers. While the on-block resection rate, it seems to be a higher rate with the use of the EFTR as compared to submucosal tunnel for a gastric gist resection. So I think in summary, Perot endoscopic tumor resection or STIR serve as a novel first phase endoscopic technique for resection of submucosal tumor without the full fingers perforation in the GI tract. While I think that nowadays EFTR is becoming a more mature technique for resection of GIST, it can achieve adequate resection margin without cutting into the tumor capsule and in theory reducing the rate of local recurrence. So thank you very much.
Thank you, Philip. Very beautiful, very interesting topics. I think you have a question. Yes, please. Professor Chiu, you can proceed with your question with the poll.
Hi, I think I have some problem with my Zoom. Somehow it stopped responding. Okay, now it's responding now. Okay, yeah, okay. So I have a poll. Can you see the question?
Yes, now the result is coming, Philip.
Okay, I cannot see actually because my Zoom is somehow not responding the program.
It's okay. The answer is that it should be the laparoscopic endoscopic collaborative surgery, 62% for this question.
So I cannot win over. I cannot win over GV. Yeah, please continue because the system is hang, but I can still. Okay, so the second. Okay. Can you continue the question?
Yeah, I will. What is the main
Please
worry?
continue.
Yes, when closing the treatment of, when choosing the treatment for gastric cyst. So the main worry is everything. The unmarked resection surgical technique that you are familiarized with, and also the patient outcome and recovery, means all above.
Okay.
Next,
I think next, please.
You can do.
No, I cannot. Please, Suthep, I cannot see it.
Okay, as the endoscopic treatment is increasingly performed for the treatment of GI neoplasm, would you consider learning more about endoruminal surgical treatment? Should the endoscopy be collaborated in the surgical curriculum? Yes or no? Or learning already took all the time, or limit to local resources? And Philip, congratulations! It called yes, 80%, or
okay,
already in collaborated.
Thank you.
That's all. Any comment? Any questions from the panelists to Philip? Very interesting, both of you, GV and Philip. I think this topics, this session is very, very interesting. I think we have 10 minutes for the question and discussion. If it may have any question, we can discuss before we getting into the alumni of the APEL for the video session. Or we can move. Yep. Please, TV.
Yeah, I think we have had some very beautiful lectures on all sides, esophagus, stomach, and this thing actually, I think, thank you. I mean, we should thank all the faculty for all this. Philip, actually, one question that we have actually right now, my hesitation for doing an endoscopic full thickness resection or an endoscopic submucosal resection has been that the entire margin is marked out based on a distended stomach. You think, suppose we mark it laparoscopically and then do an endoscopic dissection, do you think it would be more, we get a more wider and a better R0 resection?
Yeah, I think it's a very interesting idea, and yeah, I think that's the idea of the laparoscopic endoscopic colorectal surgery, and also, in principle, to align with APELS too. So to combine the laparoscopy and the endoscopy. From, as you can see from my video, I need to look at the outside of the serosa, so that I'm be sure about the tumor margin. And you'll be surprised sometimes when you're looking at the inside, you cannot estimate how much the tumor component will be from the outside, even with the CT scan or the EUS. So I think it's very important for us to understand. And of course, if the ultimate challenge will be completely doing something from inside. So
Absolutely.
at this moment, endoscopy is limited by the technique and also the instrument. Yeah, so but maybe in the future we can do that.
I think if Michael Lee accepts acting, maybe Apple should have a poll or a panel, or we should get out a white paper and we should pull up some data from Asia Pacific region, from all the board members, panelists from that side. Maybe we can draft a thing and then we can have this cooperative surgery, whatever is being done, so that we can have a good publication from APEL's side.
Interesting idea. Probably we can do that.
Yeah, maybe we can do that.
Yeah.
Actually.
I have a question.
So I think, yes.
Professor Philip Chiu, you answer first. Answer first. Yes.
Oh, please.
Okay, I have a question for Professor Joong Park. Professor Joong Park, yes, because
yes, I'm here.
You use linear stapler for before anastomosis on total gastrectomy. But when you close the opening by using stapler, do you suture the junction of stapler? Because the junction of stapler that's weak, easy to leak there.
I prefer the linear stapler when close the common opening. Only the anastomosis level is very low, intra-abdominal. However, if the anastomosis is very high in the mediastinum, we cannot use a linear stapler. We should insert through the thoracic cavity. So at the time I use suturing. However, intra-abdominal part, because using linear stapler, we can save time. However, we should be very careful for preventing stenosis.
Because you use two stapler, the junction of stapler, the junction two stapler is very important. We have to iron way suture that. Or we use the velox stop suture to close the opening. It's better to use double stapler. Yeah.
Double stapler technique.
Yes.
Okay.
Thank you, panelists. Very interesting. I think because of time interest, so let me give the session to Philip for the next, which the troubleshooting session, meet the expert. Please, Philip.
Thank you, Suthep. So I think we should move on to a case discussion. And I think today we have some sharing of the case from our previous surgeons who have gone through the APELS training. So we'll be very excited to learn from them and their case sharing. So without further ado, may I invite the first speaker?
Hi, can you hear me?
Yes, you are perfect. Please proceed.
Yeah. Hi, I'm Dr. Eric Joong from Hong Kong, North District Hospital. I somehow have some technical problems that I cannot share my video. But anyway, let me share my screen first. So I have been to the first APELS school 4 years ago for the upper GI courses. It was very useful, and since then I have been polishing my skills in laparoscopic surgery and laparoscopic upper GI surgery. Today in this troubleshooting session, I would like to share with you actually not one particular, but some scenarios that I have occasionally encountered during my practices in laparoscopic gastrectomy. So I named this presentation Fomenting After Laparoscopic Distal Gastrectomy, which is probably I see as somehow a nightmare after an apparently smooth operation, at least from my perspective. So I would like to show you the case. So this is a 77-year-old male who enjoyed remarkable past health. He initially presented to us for gastric outlet obstruction and also weight loss. On upper GI endoscopy, we found that he had an antral cancer with an obstruction. Biopsy came back to be adenocarcinoma. So at that time point, we also put in a feeding tube to optimize his nutritional status. And CT came back, other than the tumor, which showed no local invasion. There was some enlarged perigastric lymph nodes. Otherwise, there were no distal metastases. So we performed a laparoscopic distal gastrectomy, D2 dissection, and at my center, the routine is a roll and wide reconstruction. The procedure was uneventful, and the pathology came back to be T2 and 2 with a clear margin. So I would like to show you the video first. Okay. Okay, are you able to see? I think you are able to see the video now. So for laparoscopic distal gastrectomy, I use the 5-port techniques and also a liver retractor at the epigastrium. The first step is to enter the lesser sac through the omentum. And then subsequently, I would go on the left gastroepiploic side first. First to deal with the left gastroepiploic artery and vein. For the dissection, I usually use harmonic ACE and to use the Hemo-Lock for clipping of the vessels. Subsequently, here I'm showing the dissection of the lymph node station 6 dissection. I've already dealt with the 6V lymph nodes, and now I'm dissecting over the 6A region over the right gastroepiploic. Subsequently, I usually do my distal transection after dissection of the retroduodenal and also supraduodenal area. And then I would dissect over the suprapancreatic region after dealing with station 5 and also station 12A. And so here I'm showing the dissection of the left gastric artery. At this time point, I've already divided the coronary vein. So after transecting the left gastric artery, I'll do the proximal transection with an endo-stapler device, making sure that I have adequate margin while not leaving too large gastric remnant. Subsequently, I will usually retrieve my specimen through an extended port site and do an extracorporeal jejunostomy, close the mesenteric defect, and then subsequently perform this anticolic posterior gastrojejunostomy using endo-stapler device. And then I will close the enterostomy using this self-locking sutures. Usually I will use 2 sutures from the 2 sides and then, well, tie the knot together. While doing this suture, I'll try to make sure that I have adequate bite, but not too much bite, so that I won't close down the lumen of my anastomosis. After the 2 anastomosis has been performed, I would then make sure that all the hemostasis is performed, adequate dissection has been done, and also to set the peritoneum dry. I always check the orientation of the whole reconstruction from the first anastomosis down to the jejunostomy to make sure that all potential space has been closed, and then the orientation is good and there's no other twisting. So for my questions, in this scenario. So this patient actually came back on 3 weeks after the operation for some reflux and also vomiting after eating, after the discharge. And on OGD, we found that the anastomosis mildly swollen, but actually we can pass through the scope easily. There was no stenosis or any remarkable folding. Fortunately, this patient was able to solve with PPI and then proceed with the adjuvant chemotherapy. So this is the endoscopic picture. I would like to put up this question because I occasionally encounter this type of scenario, which patients would come back a few weeks after the operation because of this type of vomiting after distal gastrectomy. I've looked in the literature, there seems to be no definite good management strategy for this type of scenarios. For this type of scenarios, I think the goal is to rule out any complication, to maintain the nutrition, and also to prevent any delay in adjuvant therapy. There's a whole lot of differential diagnosis ranging from mechanical complications and functional complications. But I feel that in this type of scenarios, actually a lot of time is multifactorial. So in our center, we routinely do OGD to rule out any mechanical obstruction, CT to rule out any complication. And in the literature, sometimes radioisotope tests are due to rule out gastroparesis. For the treatment, perhaps I will leave this to the discussion. But I have a feeling that prevention is key. That once you have encountered this scenario, it is more or less multifactorial modification. We need to modify the diet, try some medication, which from personal experience, I don't think is work really well all the time. I've also read that some centers would do uncut Roux and Y to improve any chance of Roux stasis syndrome. So perhaps I'll leave it to your recommendation and advice to me to perfect my patient and safe stomach. Thank you very much.
Eric, thank you for your nice presentation. Can you hear me?
Yes, Professor Pat.
Yes, because I'm designated as a lead panelist. I am saying some comments and questions for you. So like your title, smooth operation, I saw your video very well, so very smooth operation. So now is the patient the patient okay now, or there any recurrent obstruction symptom?
For this current patient, he was able to then tolerate diet on conservative treatment, medical treatment, and then the patient actually is able to be discharged and is now undergoing chemotherapy. But I had patients that had the same situation, which we are forced to put in a feeding tube for the nutrition, and then the patient go on to chemotherapy with a feeding tube. So it creates some stress to both the surgeons and also the patient. In the end, this particular difficult case were able to also treat conservatively after 2 months.
So Dr. Long, what is your opinion for the reason of some obstruction symptom for this patient?
Yes. Because the case he will fall anatomic by Joong Park technique. But I think that's the vomiting after distal gastrectomy. The most cause due to the obstruction, anatomic obstruction, and paralysis sometimes rare. But I think that we have to for the patient vomiting after distal gastrectomy. The firstly, we have to check the anatomy first, and after that we use some medicine. But for other reasons, I have no experience because as some case due to the anatomic obstruction. Yeah.
Yes, right. We should consider anastomotic mechanical obstruction due to anastomotic some problem. But Eric examined might be endoscopy, but there was no mechanical obstruction. But the patient complained of delayed gastric emptying or some obstruction symptom. So, Eric, so what's your conclusion for this patient vomiting cause?
Well, I think for this particular patient, most of the time there is a combination of factors. On the mechanical side, perhaps there is still some, because the patient initially able to tolerate that quite well, and then the situation actually worsened after discharge on day 7. So probably there can be some mechanical issues, for example, swelling over the anastomotic side causing some functional obstruction. And perhaps it is also contributed by other issues like post-op. There's some incidence of gastroparesis, which is common after laparoscopic distal gastrectomy. So I think it's multifactorial most of the time.
Yes, the most frequent cause is temporary edema around the anastomosis, and sometimes the anastomosis was kinked. The angle was not good, especially when we make gastrojejunostomy, the posterior wall of stomach. Sometimes jejunostomy were kinked and functionally obstructed, but endoscopy when we perform endoscopy blow the air, so the anastomosis opened, but in usual time the collapsed the anastomosis. So many multifactorial causes there are. So Eric, what is your favorite anastomosis method after distal gastrectomy in your hospital?
You mean the distal gastrectomy for the GJ, right?
Yeah, yes. Pilot 1, Pilot 2, Ruang Y, and Uncle Ruang Y. There are many methods.
Yeah, for us, in our center, our favorite type of reconstruction is still Ruang Y reconstruction. And we also routinely close the mesenteric defect to prevent any internal herniation through the mesenteric defect.
Okay, I think really interesting case, and thank you very much, Professor Park and also Dr. Eric Joong for the comments and discussion. We have to move to the next presentation. So who is from Dr. Suprato from Indonesia. So, and the moderator will be by Dr. Hon-Chi Yip.
Yes, so I think we should start the presentation.
Thank you, doctor. I want to share screen. Can you see my slide?
Yes, yes.
Thank you. Good evening, good day, everyone. Thank you for the opportunity for me to share my case about posterior gastric cyst organized by APELS. This is my CV. This is the case, female 68 years old with epigastric mass. From the upper study, GI study, we found a mid-gastric tumor suggestive of gastrointestinal stromal tumor. From multi-slice CT abdomen, we found a posterior gastric mass with size 10 by 6 by 5 cm. After that, we propose laparoscopic surgery. Can I share my video?
Yes, yes.
Sorry. Share screen. Yes, this is the explore the gastric. Open the laser sac to see the posterior side of the gastric. We found no in the serosal, no tumor in the serosal. We open the anterior side of the gastric wall. And we see the posterior gastrointestinal stroma tumor, and we dissect submucosally. Sometimes bleeding can happen. And this is the right side of the tumor. This is the upper pole of the tumor. And this is the niche. And we dissecting until all the tumor release. And then clean up and suturing the submucosal or posterior gastric wall. Continues. A layer with the absorbable suture. And tying. And cut, clean up, and after that we closing the anterior gastric wall, all layer. Continuously with dub suture, 3-0. And at the end, we interlocking. And clipping. And cut. After that, clean up the and leak test. And extract from the tumor with the specimen bag from Pfannenstiel site. This is my port placement, and this is the specimen tumor. Thank you for your kind attention. I want to share my difficulty. This is my difficulty. Big tumor in the posterior gastric wall, suggestive a submucosal tumor. And how about the free margin? And how about spillage tumor cell in the operation? And I think suturing skill is very important. And the information post-operative pathology result, gastrointestinal stromal tumor, gastric with CD117 positive. Now patient in good condition after 7 months, given imatinib post-operative. And I want to solve to overcome this procedure. Laparoscopic submucosal dissection for posterior gastric cyst is feasible and have a good outcome. Thank you very much.
Thank you so much for your nice presentation. Can I ask a question? Was the cyst ulcerated on the endoscopy?
Sorry?
Was there any ulcer or erosion on the surface of the lesion in the endoscopy?
Yes. In my video, Uh,
I think I
and
saw a dimple
niche.
there.
Yes, like a dimple niche in the mucosa.
Yeah, I think it's a very tough case, given that you have a 10 centimeters mass in the submucosa in the posterior wall. And obviously there are many options available. An ulcerated tumor for GIST, to me, I think I would preferably not to open up the gastric wall as much as possible, because that is the risk of inducing peritoneal contamination in an ulcerated tumors. So I think oncological principle might be one of the first goal in performing even for GIST surgery, because such a large GIST is likely to be a high risk GIST. So but going back to options here, I think Professor Rao has done a very good summary of what we can do in such situation. One of the approaches you have done is to open up an anterior gastrostomy to tackle the posterior one. Do you have endoscopy support in your operating theater?
No.
Yeah, so that's also a difficult, because you couldn't see the tumor even when you dissected into the lesser sac. So if you have an intraoperative endoscopy, I think that would also help you a lot to identify the lesion. In that case, you might be able to just do a wedge. If the lesion is feasible, then you can save opening up the gastric wall. The other option you can consider is as you do a transgastric resection. But if you have a good intraluminal portion, you can actually just staple it off instead of doing a suturing or a dissection with the energy device. This also saves time and also gives you a good outcome. So you invert or invaginate the lesion into the lumen and then apply an endo-GIA stapler inside the stomach wall intraluminally. So that's also one of the options that you can consider. But of course, it depends on the morphology of the tumor, whether this is feasible or not. So a large tumor is always difficult, I must say. So perhaps GV, do you have an opinion or a comment?
Do you have the histopathology of this tumor by any chance?
Yes, the histopathology is gastrointestinal stromal tumor with CD117 positive.
And there are no malignant changes in that, actually.
Only that, like that.
So any mitotic count, for example?
The mitotic count?
Mitotic count, I not see there.
Yeah, very right. Actually, what was discussed, actually, it's a more than, it's a huge tumor, 10 centimeter, likely chance of malignancy. I'm not sure, actually. I think I differ even in endoscopy, laparoscopy, cooperative surgery. I think more a resectional procedure would have been better. I personally feel, because it's a 10 centimeter GIST. So I think rather than trying to do more conservative surgery, I think a more better resection would have been better in this. Anyway, what does the other panel think, actually?
Let me ask.
Yeah, Park, yeah.
Yes, in Korea, if the tumor is more than 10 centimeter and if it was proved GIST, we can apply Gleevec, neoadjuvant Gleevec first.
Yes.
Tumor
Another
after
option.
shrinken, we can do very easily for laparoscopic wedge resection later. That is also another option.
Yeah, absolutely. Yeah, that's another one.
But Gleevec is very expensive. I'm not sure Indonesia, they are willing to pay for the therapeutic treatment of Gleevec before surgery. I think, I understand the limitation in Dr. Bambang Suprato's area of concern. I also agree that if you had an endoscopist around, you probably don't have to go through the trans-anterior approach and having to close two anastomosis. You can do the posterior resection.
Thank you.
I think if possible, yeah, we should get FNA. We should move on, right, Professor Chiu?
Yeah. I think we should move on. Thank you very much for comments and the presentation. So our next speaker should be Dr. Ranjiv Rao. from India, and we have Professor Takeuchi as a lead panelist. Dr. Ranjiv?
Yeah, good afternoon. Good afternoon. Greetings from Hyderabad, India. Thank you for the opportunity given to me to present a case, a rare case that had happened to us in the year 2019. Yeah, is my screen visible?
Yeah.
So this is, yeah. So this is a case of a 55-year-old female from the local area who came with abdominal discomfort with the weight loss and a loss of appetite. She didn't have any obstructive symptoms nor any bleeding. Blood investigations were normal. Performance status was good, and nutritionally she seemed adequate. Endoscopy showed an incisura ulcerative proliferative lesion extending proximally around 2 centimeters and distally also towards the antrum. There's no outlet obstruction. Biopsy was adenocarcinoma. CT showed that the fat planes were well maintained. There were few non-bulky perigastric lymph nodes and laparoscopic subtotal D2 gastrectomy was planned. So this is when we went ahead with the surgery. I'll just share the video. So the lymphadenectomy part was carried on as usual, and then we proceeded with the duodenal transection, and everything seemed all right till then. Once the duodenal transection was done, we proceeded with the further lymphadenectomy, and then the stage came that we had to resect the proximal margin. So that is when we asked the anesthetist to withdraw the nasogastric tube, and this is what we noticed. The nasogastric tube seemed to have got trapped in the resection line, and that is when it was a challenging time for us. That is when we had to seek the help of the seniors, and then we had to salvage this mistake of us. So there were many ideas suggested, and this is what we followed. We cut open the proximal stump, and then we had to divide the nasogastric tube so that it could be retracted back into the stomach and replaced with another. And the duodenal part also was challenging because we couldn't damage the duodenal stump. So what we had to do is, again, the peritoneal aspect of the duodenum was opened, keeping a small portion of the nasogastric tube intact. And then similarly, it was divided and the rest of the tube retrieved, as shown there in the video. So yeah, so that shows that the tube was retrieved back, and then the remaining stump was closed with interrupted sutures. Postoperatively, the patient had surprisingly uneventful recovery. And biopsy showed that it was a moderately differentiated adenocarcinoma. 21 out of 28 lymph nodes were positive. Margins were negative, and it was T3N3 lesion, and adjuvant chemotherapy was advised. And the last follow-up in March, she seems to have not had a recurrence. So this is one of those cases where you are held in a very difficult situation and you had to come out of it, and we could manage to get out of this. But I think we need to put a mechanism in place so that this thing doesn't happen again and again. So I think one needs to understand the mechanics of the stapler, including bailing out if suppose there's a malfunction. So one has to have had a good training for that. And the checklist before firing any stapler, I feel, is very important, just to know the status of any tubes. Sometimes one may not, if it is a nasojejunal tube and a nasobiliary tube particularly. If it's a nasogastric tube, the chances of it moving into the duodenum is very less likely. But in our case, unfortunately, it had happened that the nasogastric tube had gone into the duodenum. And suppose it were to be a case of a neoadjuvant chemotherapy for a tumor, we may have to even note the tumor morphology, because sometimes there will be a large lesion in the distal stomach which may have obstructed, but with the good response to the chemo, it might shrink in size, allowing the Ryle's tube sometimes to pass up to the duodenum. So these are the things which I thought one should bear in mind when doing laparoscopic gastrectomy. Never be complacent. Always follow this checklist during any laparoscopic surgery for that matter. Thank you.
Okay, thank you very much. And I'm sorry that the lead panelist would be Professor Suthep, if you're here. So I think, well, Suthep is here. Okay. So yes. I have one question to ask. It's actually not an uncommon incident that we transected over a NG tube. In fact, we have experience in not only the duodenal stump that we have transected, but also at the esophagus during the total gastrectomy, or even at one time I have an experience of transecting the NG tube, which have already been pulled out, but pulled back by the ovule that I pass. Actually, they pull out into the oropharynx, but then pull back by the ovule. So there's a lot of these kind of challenges. So, at what point do you think we should convert to open, or we can actually manage all this by laparoscopic? Any comments from the panelists?
Philip, Lanjit, this situation, probably everyone also having the experience. So, yes, I think for Philip, to respond to Philip's question, I think we can manage it laparoscopically. That's why the training should be, several techniques that you can manage, like Professor Park have shown to us, that you have to have several variety of techniques that you can deal with, not only the linear, not only the circular, but you have to have a variety of technique. Any add from Professor Park?
Yeah, thank you very much. Even I had several experiences of NG tube entrapment, not only duodenum, but also resected proximal stomach and even the esophagus. But I don't have open conversion cases, so we can control that NG tube entrapment. But the most important thing is we should prevent it. So checking whether there is NG tube inside, we should check before firing of linear stapler. I really enjoyed your video. Thank you.
Thank you, Lanjit. So we need to move to the last presentation. Thanks, Lanjit. Then next, it's Dr. Dennis. Please proceed for your talk, for your video presentation. Dr. Dennis Chen.
Yes, and can you hear me?
Hong Kong, yes, please proceed.
Good afternoon, all the panelists and all the experts. I'm Dr. Lam from Hong Kong. It's my pleasure and honor to be invited to talk about my experience in laparoscopic surgery. Today, I would like to share about a case of a thoracoscopic esophagectomy with apparent vascular anatomy. My patient is a 65-year-old gentleman. He was diagnosed, newly diagnosed carcinoma of esophagus at the middle third. And he also presented with a metastatic tumor over the left supraclavicular fossa, which is confirmed by fine needle aspiration cytology. Other than that, the PET-CT staging showed no distant metastasis. He was undergo the neoadjuvant chemo-irradiation by the cross regime. And after that, the post-chemo RT PET scan was showed interval improvement of the esophageal tumor, but there was still significant lymph node nodes at the mediastinum and the left supraclavicular fossa. I plan to have a minimal invasive esophagectomy and a complete mediastinal dissection and lymph node dissection for him. Let's take a look at the preoperative CT scan. And you can see that on the left side is the cut at the carina level. You can see there's a vascular structure in between the esophagus and the spine. And on the right side, there's the similar cut that shows that the vascular structure was actually originate from the aortic arch. And you can also see that the primary tumor is quite close to the origin of the subclavian, of this aberrant vessel, which arises from the left side of the tumor. And actually, we made the diagnosis of aberrant right subclavian artery on the CT scan. And the potential difficulty that I encountered in this operation included, as I mentioned, the tumor is quite close to the origin of these aberrant vessels, which arise from the aortic arch. And also the area is after irradiation, probably I will encounter scars and adhesions. And the bilateral upper mediastinal and paratracheal dissection can be distorted by this vascular aberration. Especially this condition is associated with a non-recurrent right inferior laryngeal nerve. And also the thoracic duct might be having an aberrant course and it might terminate it on the right side rather than the left side. So let's take a look on the video. Sorry, can you see the video?
Not actually. Could you try it again?
Okay. How about now?
Now you're good.
Yes, okay. So I operate my patient in a prone position and I start at the lower mediastinal. And for the lower mediastinal dissection is quite standard in this operation. And apart from that, the thoracic duct is controlled at the hiatus level, and I double click it and divide it. And let's move to the upper mediastinum, and you can see that there is a pulsatile structure between the spine and esophagus, and which correspond to the aberrant right subclavian. And I open up the pleura and identify the vagus nerve, and hoping to identify the cause of the subclavian artery before I proceed on further dissection. And I trace up the right vagus nerve up to the origin of the aberrant right subclavian. And I'm hoping that doing this, I can see the whole course of the aberrant right subclavian artery. And you can see that this is the right subclavian artery, which is aberrant in course. And I further expose the course of the right subclavian artery, which is between the spine and esophagus. And you can see that there is no recurrent laryngeal nerve poking around the usual anatomy. And I resect the right paratracheal nerves. And I further resect the artery away from the esophagus and opening up the left paratracheal space and doing the left paratracheal dissection. And I retract down the trachea and up the esophagus, and this is the ventral side of the lymph node bundles of the left paratracheal space. And you can see the left recurrent laryngeal nerve. And I use only use sharp dissection and avoid thermal injury to the nerve. And after resecting this ventral part, I move to the dorsal part. And you can see the significant scarring after irradiation. And nerve is underneath the dissection. And after some dissection, the tumor is able to be dissected away from the aortic arch and the right subclavian arteries. And this is the recurrent nerve on the left side. And I transect the esophagus and do the subcarinal lymph node dissection. And because this patient has enlarged lymph node over the subaortic area, and I also dissect and resect the lymph node over the aortic pulmonary window. And this is the lymph node dissection over the aortic arch and away from the left pleura. And this is the last bit of dissection, but I've got to be very careful because of the nearby pulmonary artery and the recurrent laryngeal nerve on the left side. And this is the final bit of the dissection. And you can see the final dissection. And this is the aortic arch, subclavian artery, and the recurrent laryngeal nerve. All the lymph nodes are resected, and over the right side, there is no recurrent laryngeal nerve on the right side. And the subcarinal lymph nodes are also resected. Sorry. So this patient had uneventful recovery, apart from some mild cow leakage. And it resolved on MCT diet, and it can be discharged without any major problem. And the pathology come back to be a poorly differentiated squamous cell carcinoma, T3N1. And in this case, I would like to bring up that an accurate preoperative imaging to identify vascular abnormality is critical. And I always prefer the CT scan with vascular reconstruction. And this condition is uncommon, but it should be always be bear in mind when we do esophagectomy. And this aberrant right subclavian artery can have impose some risk on the dissection on a safe area, which is usually considered to be the area between the spine and the esophagus at the upper mediastinum. But with the presence of this artery, it can be no longer be safe. So injury, or if you are not able to identify this vessel, may need to have a great consequence. For example, upper limb ischemia. And also secondly, the non-recurrent right inferior laryngeal nerve may pose a little bit difference on the lymph node dissection, especially on the right paratracheal space dissection. And last but not least is the thoracic duct. And we have to be very careful to identify it because this condition also accompanies the thoracic duct abnormality. And preoperative MRI may be useful for preoperative imaging. And I believe that if I'm so lucky that if I have a similar case in the future, I may need an MRI scan to carefully locate the cause of the thoracic duct and to avoid the complication of the cow leakage. And this is the end of my presentation, and I welcome any comments from the panels.
Thank you, Dennis. Congratulations. Nice presentation, and also a challenging anatomy. So as you mentioned, so for thoracic esophagectomy, could you give us the most serious or most concerned part that you have, everyone have to be, you know, dealing with during the surgery?
I think in our practice, we usually have a patient with advanced tumor, and they usually will undergo a neoadjuvant chemoirradiation. So most of the time we encounter a patient with a very significant scarring at the subcarinal area or at the middle third of the esophagus. And that area usually had a lot of important structures, including the airway, aortic arch. And to do a safe dissection, we really have to plan carefully preoperatively and have a very meticulous skills in doing the dissection. Because if we do not able to, for example, in this case, if we are not able to identify the vascular anomaly, and there may be a tremendous danger to the patient, like injury to the subclavian artery in the thoracic cavity, and that may lead to very disastrous outcome for the patient. So I think to balance the safety and the oncological outcome for this patient, we always should have a better, good preoperative planning before our operation.
May I invite Professor Takeuchi to comment and also maybe to respond?
Okay. Dr. Dennis, can I have some comment and questions?
Yes.
First of all, I'd like to congratulate your, successful treatment for this difficult case, and excellent surgery. Thank you very much. And I completely agree with your point. Some points you mentioned in the last slide, and I have a couple of questions. One is, can you maybe you cannot identify the right recurrent range node, right?
Yes, yes.
Yeah. Also, I have several cases with this aberrant, right subclavian artery that we cannot identify the right recurrent range node in those cases thoracoscopically. So maybe, as you pointed out, non-recurrent case pattern of these aberrant arteries. And also, second question is, can you follow the route of thoracic duct and up to the, right subclavian vein totally?
In this case, I cannot, because I can identify the thoracic duct in the lower mediastinum.
Yes, yes.
Yes, but when they travel up to the superior mediastinum due to the scarring and fibrosis, I cannot really identify. So I just divide at the lower mediastinum and hoping that there's no cow leakage. But unfortunately, the patient still have some mild leakage of the cow. But luckily, he resolved on some conservative management.
Yeah, I completely agree with the procedure. You ligated the thoracic duct in the lower mediastinum, right? That to prevent a major chiral leak after esophageectomy. That's a good point. And also, I'd like to ask you about the reconstruction route. Maybe in this case, the posterior mediastinum, upper posterior mediastinum space is not so, big. So you choose the posterior mediastinal route or post-sternal route or subcutaneous route or something?
In my center, we usually do a posterior mediastinal route. And yes, in this case, we still use our usual practice. And of course, there would be some disadvantage. For example, if there's local recurrence, then there will be some problems regarding the gastric tube. Yes. But for us, we are very familiar with using the posterior mediastinal route, so we just keep on using this route of reconstruction.
Yes, maybe routine preoperative 3D CT imaging of the artery to identify the aberrant, route of the artery or vein, and also maybe preoperative MRI to identify the route of thoracic duct. Not 100%, but sometimes it is useful to identify the route of thoracic duct. Thank you very much.
Thank you very much. Thank you very much.
Can I ask a quick question to Dennis and Professor Takeuchi? So in this case, without a non-recurrent laryngeal nerve, I presume you also did a neck dissection as well. So were you able to find the same non-recurrent laryngeal nerve in the neck? And how do you prevent injuring it during the neck dissection?
Oh, okay. You can identify the right vagal nerve, right?
Yes.
From the right neck, and you can see, maybe you can see the very tiny, very thin branch from the main vagal nerve. Maybe that is the non-recurrent laryngeal nerve, I think.
I see.
Yeah, but you can find a similar branch I don't know. I'm not sure, but maybe you can find the several branches of the nerves.
In this case, the patient had a left side SDF lymph node metastasis, so we embarked on left SDF dissection. So on the right side, we didn't really we didn't really do a right neck dissection. So actually, we didn't try to attempt to identify the recurrent nerve on the right neck. So what I do is just do a right paratracheal dissection along the right vagus up to a stage that I cannot really reach further superior. And that's the limit of my right paratracheal dissection.
I see. I think when I was in Japan, having training with Professor Kanaya, so he told me he have only seen 2 cases in his whole career. So it's lucky that you've seen this and tackle very nicely this case. So thank you very much.
Thank you very much. Thank you very much.
Okay, thank you. If there's no more questions from our presenter, I think we'd like to thank all the participants, especially because you have gone through the APELS course, and then afterwards it is really a very good completion of the APELS training that you come back and demonstrate to us how good you are at this moment, and we are truly delighted to see that all of you has been excellent in your technique and applying all what you have been learned during the APELS course to your clinical practice. So thank you so much for all the alumni presentation. And I think while we are still scoring the presentation, that we have actually the Best Presenter Award in this APELS webinar. And I think our secretary needs some time to make the score before the announcement. But during this time, maybe we can still have some discussion, and we have some polling that we'll be able to do now. So maybe, yeah, so can you see this list of questions for all the participants for polling? So do you enjoy today's APELS webinar? Will you be interested to join the next APELS webinar? And what impressed you most in today's session? So please help us to improve on a future webinar.
I think overall we had a great session, Philip. Actually, I think all the faculties did great job. The questions were very good. The APELS secretariat did a great job in coordinating the whole thing. I mean, if you see, there are no hitches during the entire program. Everything went up absolutely smoothly. And then again, the credit goes to the president, actually, Michael T., who sits on the top to make sure that everything runs on time. Absolutely, time management has been good. So I think overall it looks good, actually.
Well, can they show their face to let the audience see who they are?
Yeah.
Karen, Kadora, put yourself on the screen. For excellent job, well done today.
Hi, everyone.
All right.
Congratulations.
Hi. Sorry, we were just brushing up the administrative work here, but thank you. I hope you all enjoyed the section today.
Excellent. Well done.
Got the answer right. Yeah.
Okay, and I think we have already got the score, so I'd like to invite Professor Michael Lee to announce the best presenter. Professor Lee, please.
Wait a minute. They haven't given it to me.
They will provide you with the name.
Okay. I just seen it in my WhatsApp. Well, I'm very pleased to announce for this session of APELS presentation, Dr. Dennis Lam has the highest score. Congratulations.
Thank you very much. Thank you very much.
Congratulations.
Thank you. Thank you very much. Yes, thank you very much for all the organization, and also I think the participation. And I would like to invite Professor Michael Lee to say a few words for the closing remarks.
I think it's been a very great session today, and the program organized by Philip and GV has been excellent. And the content, well, you know, I can't match the faculty that you created. It's fantastic, and I hope everybody agree that, you know, we do appreciate the participation of all the people who attended the webinar. I'd like to thank everybody and hope to see you soon for our next webinar.
Actually, I just put it on record. Actually, we had my IT department tells me that there are about 688 people who watched this on this side, on the Facebook and all. Actually, people who are not registered yet.
When we were live on Facebook, there were people watching beside participants.
Yes, beside participants. Yes, actually, yeah. That's a good thing. Actually,
150 people. I think Facebook was also very popular.
Very good, actually. I think more and more people will watch this program because it is continuously there on the thing. Actually, we'll hope that more people will watch this.
Well, there'll be more to come.
Yes.
Thank you so much. Thank you, APELS.
Thank you so much.
Thank you.
Thank you.
Thank you.
Hope to
Thank
see
you.
you all face to face
Thank you, Prof.
next
Thank
year.
you so much.
Thank you. Thank you.
Thank you for
Bye.
Thank
Thanks everyone for great efforts.
you.
Have a good weekend, everyone.
Bye.